Good morning, good morning, good morning. Welcome to Bradford Health Services' second continuing education event for 2026. I am Zach Ludwig, Vice President of Clinical Services and Accreditation for Bradford Health Services. I will be your moderator and presenter for all of today. If you've played along at home with us before in previous sessions, you know that we bring a mix of different presenters throughout the year. We started off 2026 really strong with a quality presentation. I hope to follow suit with that today and give you your continuing education hours in ethics today. We are going to do a 3-hour session titled Ethics for Professionals. We are already in the planning phases for our Q3 webinar, which will happen in September. And we're going to have a really quality presentation about substance use and mental health treatment for professionals, which I think will be of interest for a lot of you on here. I do want to personally thank everybody who's joining us today. Right now, we are up to 755 participants and we are climbing. This has proven to be one of our most popular offerings yet in our history. We have been offering quarterly webinar trainings basically since COVID 2020, and I'm excited to continue making these offerings available to you. Wonderful opportunity to engage with all of you. I see so many familiar names. I can't say I see familiar faces because I can only interact with you on Zoom chat, as so many of you are doing right now. Love it. Keep those messages coming as a nice reminder. You do not need to check in the chat in order to get credit, but feel free to tell us who you are, where you're coming from. And a lot of you have already. Your attendance is being monitored based on your registration, but more importantly, the fact that you are sitting here on this call today. If you do happen to run into any personal technological issues and you get kicked out, just join back in. We monitor that. We see how many total minutes you are present, and we will certainly give you credit if you are here for the allocated time, understanding there can be some slight hiccups. All right. Okay, before we get into the session today, do want to do some housekeeping. You are viewing this in webinar format, which means, again, I cannot see you, but you can certainly, I hope, see and hear me. Your video is off and your sound is off by default. I do not believe there's a way to turn that on, so please don't try. If you want to talk to me, you certainly can. A lot of you are doing the Zoom chat. I'm going to use that throughout the session to try to be as responsive to real-time feedback and questions as possible. If you'd like to make a comment about something I'm saying, good, bad, or indifferent, or if you would like to ask a question, I can certainly do my best to give attention to that. A few of you also putting information in the Q&A box there. Good thing about the Q&A box is it will not disappear as quickly as the Zoom chat does, as it just kind of flies by. So if you have a particular thing you'd like to put out there to the QA, it will be sometimes a little bit more visible to me. I have wonderful support during this session today. Miss Sherry Schaefer is helping out. We'll be fielding some of the questions as we go. At the end of the presentation, we will potentially have some time for discussion. Sometimes I run a little bit long, but that's why I really want to be responsive to you as we go. Enough said on that. Please note that you're going to receive a post-session email that's going to include a link to all the materials. It's a very common question we get asked. I think a lot of you have already asked it. I'm going to give you a copy of the slides. I'm going to give you a link to the video recording of today so that you can go back and watch it if you'd like to be reminded of something I may have said. You will not get continuing education credit if you only view the recording after the session. You have to be live here now in order to get the credit. So please keep that in mind. You won't be able to share that with your colleagues and they get credit after the fact. Today's session is eligible for 3 hours of continuing education. In order to get that, which I know is very top of mind for you at this exact moment, you are going to get access to an evaluation link. Couple ways you're going to get it. Towards the end of today's session, we are going to pop it into the chat and in the Q&A box, and you can click it and go forth and do it. And it only takes you about a couple minutes to give that feedback, and then it will be off of your to-do list. Alternatively, if you happen to miss it, which is okay, you don't have to contact us. We are going to, in that post-session email where we send you the copy of the slides, there's going to be a link in that email. You click it there, same thing, get it done off your to-do list this afternoon. But then I need you to give us probably about 30 to 45 days in order to process that. I know that sounds like a long time, but believe me, we have one person who is processing all of this stuff in a very manualized manner because we are going through and we are checking attendance versus registration and all those wonderful things. So give us a little bit of time on that one, and then we will email that to you. If after give me 45 days you have not seen it, please feel free to email us at events@bradfordhealth.com. That is the email address that is associated with that page where you registered for this very session. So you can find it there too. Okay. I need you to get your evals in, though, folks. That's the really, really big thing. We got to get these evals done in the next 2 weeks, 14 days. If after 14 days you have not done the eval, I've got to close it and I've got to move on. So get your evals done as soon as possible, right? Okay. If you would like to complete the survey, again, it's going to come right to you today, and we are expecting a very large number of attendees. We are up to 850. All right. So give us some patience on that one, and know it is a volume game. Importantly, technical issues, if we happen to experience any. As I already mentioned, it might be on your end. Pop back in using that exact link you have. Get back as soon as you can. If I somehow have technological issues, knocking on wood that I don't, I will also attempt to join back in as quickly as possible if by chance we are unable to resume our session today. No need to call us, no need to email us. We will get back to you about what that means. And that could mean we are offering partial credit. We haven't had to do that yet before. I'm being very optimistic. It will not happen again today. It will not happen today. Alternatively, we will give information for a potential make-up session if that were to occur. But we are going to pray for good Wi-Fi and good weather wherever you are calling in from today, and that we do not run into those issues. We are going to take a break about midway through, give or take, and that'll give us a chance to stretch our legs, refresh our beverages, things like that, right? Okay. I think I've covered all of the questions, and if not, you can certainly give me a message or give me a chat, and I'll do my best to address it. Okay. A little bit about me. As I've already introduced myself, I'm the VP of Clinical Services and Accreditation for Bradford. I'm a licensed counselor in Alabama, Tennessee, and Florida. I hold supervision designations in Tennessee and Alabama. I've been working for Bradford Health Services, which, if you're not familiar, is a primarily substance use treatment provider. We operate in 8 states, mainly in the southeastern United States. We provide inpatient and outpatient services along the ASAM continuum of care. I've had the privilege of working with this organization since 2011. I've held a number of different roles within the organization, from a direct care provider of adults and adolescents. That was back when I lived and worked in Tennessee. Since 2016, I've had the opportunity to be in Birmingham, Alabama, part of our corporate management team, where I've assumed a couple of different project roles, all kind of under the umbrella of clinical services, accreditation, compliance, and things of the like. So I like to give presentations on a number of topics, but ethics is one of the favorites of mine. I always refresh this topic. So if you've joined me before, know that I've added some new content. So a lot of this is kind of things you may have seen from my previous presentations, but I'm always adding additional relevant information, and I'm also trying to keep up with the times as much as possible. So you're certainly gonna, if you hang around for me for today, you're going to get some good info on item number 6 on this slide in front of us, technology. I'm going to explore some, as best I can, information about AI and relevance for our field. I know there's already a number of training opportunities from various sources that are floating around out there. Maybe you've participated in some of those. I know I have, and I'm kind of taking some pieces of those, and then certainly my own research and my own kind of informed decision making on some of these as well. So we'll definitely get through some of that, but. This is a broad overview of what we're going to do today, and it is quite a broad topic area, and we're going to go through it in various speeds depending on your engagement, what questions you might have for various topics, and feedback you have. I try to look through this through the lens always of kind of multiple perspectives. As I said, I'm a licensed therapist, and so I will be talking through this from kind of a practical standpoint, but recognize I'm also representing a rather large agency. And so, in my role of being involved in policy development and procedural development, I can't help but kind of to look through the operational lens of some of these things, which I know, depending on where you're coming from, may make a lot of relevant sense if you yourself are at an agency. Perhaps in private practice, there are some things where we might delineate and have some different viewpoints about some of the practical elements within what we're going to talk about. Certainly, because I'm representing a substance use disorder treatment provider background, we're going to be touching on that population in great detail, and a lot of the examples that I'm going to provide are going to heavily weigh in that content, and why I think that that's valuable for me to point out. I know that not everybody who's joining us today is necessarily a subject matter expert in working with that population, but I think it's very vital that we kind of lean into discussion about that, working with that group, because you will interact with this population whether you hold your shingle out to work with this population or not. You might be calling in today, and you have a private practice where you specialize in working with couples, let's say. Well, you certainly can't remove the element about assessing and evaluating the role that drugs and alcohol might have in that dynamic, right? So hopefully you will come out of this today with being whether newly informed about an aspect of something I talk about today, or maybe reinforced that your ethical practices are sound, but maybe walk away with some additional things you want to look into to expand your competency around working with the population that struggles with substance use disorder. So. Hey, thanks for all the kudos. I'm getting a couple nice chats coming my way, specifically calling me out. Appreciate that. And glad you're here. Let's dive right in. So, first section, I want to talk about some latest news and developments. This is an area I routinely update. One of my main updates for you today is therapists out there, compact update. If you're not familiar what the Counselor Compact is, it is an interstate compact, basically an agreement between states, excuse me, that are going to allow professional counselors who are licensed and residing in one state to have a privilege to practice in another member state. As I mentioned at the top of the meeting, I have licenses in 3 states. Those are what we'll call full licenses, as in they stand independently. So that if I happen to say I no longer wish to be licensed in the state of Florida, it would have no ramifications on my licenses in Tennessee and Alabama. What the compact in operation really does is you'll have kind of your home state. I'm going to use myself as an example. My home state's Alabama. If I choose to seek a privilege to practice in a compact member state, I will have that privilege for as long as my home state license is in good standing. And so that means I can't say all of a sudden, well, I'm moving out of Alabama and I no longer wish to hold this license. It's my kind of foundational license. I have to hold it unless I seek out additional license in the state that I am moving to, let's say. this is a good thing, and you may be familiar with how the nursing boards work, which are much more national licenses, and then certainly as another comparison, social work licenses have historically have had much better portability than counselor licenses. And so much of that is driven by a number of factors. Some of it being legislative push and the fact that social workers have historically been recognized through federal programs, particularly CMS, which includes Medicare, Medicaid, where they have kind of always been written into those codes as providers. Whereas it's only been very recently that therapists are viewed on a similar plane as social workers from a reimbursement and provider standpoint from CMS. So there's that element that's kind of propelled their portability, but the other thing is better standardization across states. Which, if you have experienced educational programs across states or board requirements across states, more specifically, you know that there can be a great deal of variance in number of hours required for a degree, the courses required in order to attain that degree, and a lot of that is driven by CACREP, CACREP, which is kind of the ruling body over what is a standardized curriculum for this group, right? Anyway, so this is a really good thing, long time coming, still very much in the works, and this is what I'll show you as kind of our very latest. I accessed this just the other day because just the other day, another state got added, Georgia got added. Here's in green who the member operating states currently are: Arizona, Minnesota, Ohio, Indiana, Georgia, and Louisiana. So if you are talking to me today from one of those states, that means that you are in the compact. So if let's say you're sitting in Georgia and you're licensed there as a counselor, and you say, you know what, I want to expand my footprint and I want to now start working with clients in the state of Louisiana. Well, you can, through this process, request a privilege to practice in the state of Louisiana. And then I imagine how you would do it is by providing telehealth services, and you would certainly be eligible to do that. So that really helps with the portability across state lines. As you see, there's a couple of states that are starting to, what I'm going to use the word cluster, where they're kind of next to each other, like Ohio and Indiana are, where I imagine for practitioners in those states, there's a great deal of value currently to be had in how they can operate if you're on a border town. Again, myself in the state of Alabama, it is not yet operational for the compact, but I bet once it is, I'm going to be able to potentially add privilege to practice in the state of Georgia, which we have a lot of towns which are right there on that line, where people might live and or work in either state depending on time of day. So this again, long time coming, and I hope that you're staying up on the news, particularly if you are doing telehealth practices and live in an area in probably in a terrain where it makes sense, where you're going to have populations across state lines. At the end of the day, it's going to be a great element to expand access to care across the nation, because we know that there are just certain states where there are just treatment deserts, where there's not anyone accessible, and maybe it is that the closest practitioner is across that state line, and that might have been a hindrance before. So. I do want to point out, you can certainly go to the website, just Google Counselor Compact, and they have a pretty robust website they keep up to date on it. There are going to be some requirements around this that you may not have experienced before, such as having to take a jurisprudence exam. I've pulled on the slide here the description of what a jurisprudence exam is. I took this from the Tennessee board because for me personally, that's where I had to take a jurisprudence exam, which is basically ethics and code question exam. It's used to measure a counselor or therapist's familiarity with, in this case, the state law and regulations necessary for safe and effective practice. It asks you ethics questions, but it also asks you just practical, how many hours of CEs do you have to have in a biannual renewal period, kind of things like that. And somewhat kind of tricks you up with the language of biannual versus biennial, which I personally can confuse from time to time. So that is my big update on things that are kind of coming our way, and things I want you to particularly pay attention to if you are a counselor in this field. Now I'd like to turn to looking at some terminology framework and how we apply some of these principles. And as I said, many of these things can be applied for general ethical practice, regardless of whether you're a marriage and family therapist, social worker, or therapist, or a professional counselor, or perhaps you're representing another profession with us today. Perhaps you're a nurse or peer support or other behavioral health staff. And then I want to do some deeper evaluation of how we apply our commonly held ethical principles to the space of substance use disorder. I want to give you some information about infractions that are common in our space, and of course, some practical information about how we can keep ourselves from running into unethical practice and compliance issues in this regard. So, begin with a definition. Ethics are generally regarded as a standard that governs the conduct of a person in their profession. It is profession specific. And why I call that out is there certainly can be variance among our behavioral health clinicians. Social workers will have a slightly different code than counselors, as an example. More overlap than difference, but it is important to recognize some of those variances and understand what the rules of the road are for your profession and those expectations. Because at the end of the day, these guidelines are designed foremost to protect the client, and then to protect the profession, then to protect, well, I'd say client, society, then the profession, then the professional. And why I do that as a call out is if you look at the list that's on the slide, I list professional, or much earlier in my list. You are the technically the last person that the code is intending to protect in terms of ethical compliance. And why I like to drive that home as a message is that holding a license in this regard is a privilege, and the boards owe you nothing. So I think that I take this from some personal experience where I've worked with some clinicians who might get a chip on their shoulder about the board's communication, or expecting the board to bend to them at their behest. And frankly, if you push the board too much, they don't have to give you a license. And if there are certainly concerns about your practice from ethical or legal standpoint, if they have any indication that there might be any untowardly behavior on your report, they certainly can revoke that privilege, or make it very hard for you to practice. So let's keep in mind that we all have to work together, boards and professionals. I know that sometimes the relationship can have an animosity to it. I certainly can appreciate that. But privilege, and we must always remember it is the person and population at large that is being protected by this. And then we want to keep the profession safe by removing any potential bad actors who will bring down the integrity of our profession, because this is the helping field, which means it's the trusting field. And if we do not have the population that can trust us, then we're all going to go out of business, and that's not a good thing. But more importantly, and more damaging, is that we will have people who will not have resources for which to reach out to, and that would be a great shame. Our purpose for holding out administrative codes and ethics is certainly to educate ourselves as members as to what is the rules of the road, the ethical conduct, maintaining that accountability as professionals, and then hopefully improving our overall practice by mandating that certain things have to happen, such as child abuse, neglect reporting as one example, as well as other uh, perhaps more abstract or aspirational elements of ethics, um, and and how we reconcile all of those. I want to share with you some terms. We'll go over in some detail as we go through some examples. So, non-malfeasance, you've likely heard before, do no harm, right? And I think if you look across professions, this hits in different areas with different terminology. Medical professionals, above all else, do no harm is very much written into the principles of that profession, and very much similar in our regard. Beneficence, doing the right thing. Sometimes that can get a little bit murky when it is sometimes competing priorities, but also competing evaluation of the overall greater good in certain case scenarios. I will give you some examples of that as we go today. Justice, which we'll define as fairness and equality. And perhaps even the more pertinent word there, not listed, is equity, and general fair treatment, but recognizing necessity to lift up others when there are variances in access. Fidelity, which we'll kind of use a few general words, and that's being trustworthy, congruent, faithful. Basically, I look at that as do what you say you're going to do, and if you make a commitment, you hold up that commitment, and you present with consistency. And veracity, being honest and of course accurate in what we represent. So no misrepresentation of credentials, abilities, expertise, etc. A number of things we can talk about there as we go. And then certainly autonomy, and that's valuing each individual as an individual, and the ability to be self-directed, make their own decisions, even if on a again personal level. But we'll of course talk about how we remove our personal viewpoints from this and shield that from the therapeutic relationship. But even if something that we don't personally agree with, right? Does not matter. That's not for me to say. It's not for me to pass judgment. And frankly, I find some people struggle depending on topic nature with being able to separate themselves from that. And that, above all else, to me, is what makes for a competent minimum professional. We must differentiate ethics, which are again very much profession focused and therefore can have some variance among professions, but then how we categorize these differences from a moralistic or a value specific nature. So, morals, for comparison, I'll start there. These are reflections of kind of broad, generally societal viewpoints about how we categorize ideas, actions, decisions that are made. Thinking about examples about the dichotomy that exists: good versus bad, evil versus righteous, right or wrong, truthful or dishonest, right? There can be a level of certainly subjectivity that comes into some of those words that I have provided. But in general, we find that as a population, we categorize things in these black and white buckets, and we don't often do as good with the gray. Um, in personal values, that is what myself or you independently hold as important, necessary, what is a desire for you, what is a goal for you. Those can vary significantly, and we have certainly examples where there are overlaps in how we procedurally operate. So again, let's take do no harm as an ethical standard, right? What we would say in the moralistic of that is a good thing to do no harm, right? And I personally, as a value, hold that I want to keep people safe above all else, and I want to make sure that people are cared for, right? So there's a very easy example about how we find an alignment down the line of these three terminologies. But I'm sure you can think of examples you might have experienced in your professional work where an ethical principle, as a kind of overlay, can lead you in one direction, but then again, as a moralistic viewpoint that you might have, perhaps you view this as the negative. You view something as bad, or dishonest, or fill in your kind of moralizing word of choice, again, personal level, keeping that out of the relationship. And then what does that mean on your personal values as a person? How we reconcile all of these things is really the name of the game in a lot of ways. It is foundational in how we have to approach our work. And certainly one of the areas that can cause friction and even greater degree malpractice from individuals who are struggling to reconcile how these ideas come together in practice. We must respect the differences of those that we work with from whatever they're coming from. Cultural background, culture meaning a very, very broad word in the way that I'm using it. Um, Cultural differences, you certainly can go through the kind of high level. What are we talking about of the things that make us different, right? Gender, sex, sexual orientation, race, religion, all those uh, let's keep out of dinner table conversation things that cause concern for people. All of those things that make us different, but even within those groups where we might find homogeny, everybody represents their own culture because we all have different experiences, different upbringings. Even people living sometimes in the same household growing up come out having different cultures because of their different experiences, their different perceptions of what happened, right? Um, all of this we have to reconcile with our own cultural, ethnic, racial identity, fill in the blank of any type, values, and how that will impact our counseling process. I pull that right from ABEC, the Alabama Board of Examiners and Counseling. You will find similar language in the national ACA codes, social work boards, as well as certainly in your respective state codes. We avoid actions that seek to meet our own personal needs at the expense of our clients, right? We are aware of how our own values, attitudes, and behaviors apply in a diverse society and how we avoid infringing those upon others. I want to take a quick minute. Noticing a lot of people still adding to the chat. Excellent. Keep it coming. Reminder, you don't have to check in with us and tell us exactly who you are. We got your credit. You're in the room. Way to go. We certainly don't need any personal information if you don't choose to share it. That is not being asked of you. So I just want to say that. Okay, so let's revisit some of those ethical words I just used a few minutes ago, right? I want to kind of put this through that fun lens of substance use disorder treatment. Justice, free from bias or favoritism is a term is kind of a phrase we'll use from this, right? Within our space, within our society, there's still biases on many, many levels. Stigma is real. I like to believe that stigmatization of those with substance use disorder has improved. I can think of objective reasons why that has occurred. I gave a talk on this a few months ago at a conference in Alabama called ASADS. If you're an Alabama resident and you have not attended, please do so. If you're not an Alabama resident, you want to come give us a visit, come out to Tuscaloosa, giving my little commercial for them. Can't help it. Great content. But the Alabama School of Alcohol and Drug Studies, ASADS, roll tide, somebody says, okay, let's not go start going down that path. We're going to have a whole bunch of competing priorities there. Just kidding. But anyway, I believe that from my own personal experience of working in this field for 15 years, as well as just what I see on the street, is that we have broader access to things like MAT, or better now called MOUD. That's a stigmatization shift. We have better representation of those in recovery in media. When I can turn on a movie or a television show and see not the tropey, this person is an addict, alcoholic, to use those words, but instead is a person in recovery, and that is a sidebar component of who their character is versus being basically the full printed picture of who they are. I think that that's a step forward, and that's just an example that I recognize. Um, but yet, still within society, one area that we seem to delineate is like with drug of choice, DOC. So, people's ability to understand and conceptualize somebody who's drinking alcohol still very different from the person who is injecting methamphetamine, as an example, or smoking crack cocaine. There are variances in how society handles them, and we even certainly see among practitioners a value-laden driven moralization of these things because often they don't understand. Um, Hey, I love that somebody's called this out. I was going to get there, but great. Similar to language we use for a person with any disability, putting the person before the disability. I'm going to get there, but I love it. We're already talking person first language, right? It's person with substance use disorder. So drug of choice to me I don't care. It doesn't matter. I need to know it because that might change the avenue in which I go down for treatment. Because certainly treating somebody who's been using benzodiazepine is going to have a very different treatment plan than somebody who's been using methamphetamine. And I'm going to need to expect some different behaviors and responses from those two individuals, right? But drug is a drug is a drug, as far as I'm concerned, does not matter. And then within that regard, method of use. I need to know that because it tells me about some things I need to be very cognizant of from a might need to do some additional screening if somebody's been using IV or sorting drugs for things like HIV, hepatitis, and other communicable bloodborne and otherwise diseases that maybe I am not as worried about with somebody who's been alcohol only. However, I still need to be worried about hepatitis and other conditions. So it can inform the treatment plan, but at the end of the day, I I don't treat the person any different, but I think again, too often in our broad world, in our broad profession, there can be this stigmatization that still exists. Autonomy, allowing people to be self-directive. This is harm reduction 101, which as a treatment field, we are still getting better at, but I don't think it'll be one of those things wherever we're like there. We'll always be moving the needle, haha, not to do a pun there, but we'll always be doing that when it comes to harm reduction. So until our society fully can be wide open on needle exchange programs, safe injection sites, which are still very, very limited to just a couple of sites in the northeastern United States. Other places around the world have it a little bit more wide open, but certainly not as expansive as it potentially could be. We have to continually push managed care. We have to push our legislation. We have to push what the laws say about our ability to work with this population because, guys, prohibition doesn't work. I have to recognize that people have the self-directive choice to use drugs or drink alcohol, and I don't want to get into. I'm not trying to say this is a choice. This is a disease. It is when we say DOC, it is often a disease, a drug of no choice because it is a compulsive behavior. But what I'm saying is, if somebody sits in front of me and says, "I want to go relapse. I want to go use," I am reconciling that I'm going to do everything in my power to give you an informed information about the risks about that, and that I want to support you, and that you certainly can choose not to do that, and you can stay here with me and not go out there and use. But at the end of the day, we are all autonomous creatures, and people are going to make choices. And I respect those choices, despite my fear for them. And again, that is where I will educate, and that is where I will give all the resources I possibly can, such as how Narcan works, and doing everything I can to, again, keep people as safe as possible. You have to reconcile for yourself how the concepts that have long been driven about drug and alcohol treatment of an abstinence-based program must be challenged. Can we get comfortable with continuous treatment for somebody who is choosing to control their drinking, let's say, moderate their drinking. They were potentially drinking, let's use just raw numbers. They were drinking a case of beer, 24 beers, 12 ounces every single day. And they have now chosen that they would like to get on naltrexone. You're not familiar with naltrexone, injectable form Vivitrol in the pill form, called naltrexone. I don't know the other names. Somebody else probably does. You could take that and it helps with cravings and it reduces some of the behavioral reinforcement of the dopamine and other receptors so that when somebody is taking naltrexone and they continue to drink, they often find that they lose interest and maybe they have one, maybe they have two, maybe they don't have any that day. But man, they have been able to use a medication element in order to help their behaviors. And by doing so, they are now drinking less. And I would much rather have that person who is either with medication aid or potentially, if they're able, without medication aid, who has taken their 24 beer utilization down to 12 or 6 or whatever it is, whatever their goal is, I'm on board, right? Because we never let the best be the enemy of the good. And historically in this treatment space, that has been the elephant in the room, right? Okay. Non-malfeasance, do no harm. Thinking about not only the potential harm we inflict kind of an explicit, overt level, but thinking about how harm can occur when we are not our best selves. If you are burning out, if you are, not taking care of yourself in one form or the other, the unintended consequence that can happen in that way. We're going to talk a little bit about burnout later on. I got to keep moving quicker. Decisions about discharge, discontinuation. So basically firing a client or terminating care. You might use different terminology depending on your setting. There are times and places where we need to terminate care, and particularly if that is going to be something that is a safety sensitive situation. Again, we have to work with that population, be creative as much as we possibly can on meeting these folks where they are at, and then making sure that termination occurs in the most conscientious way possible, the most protective way possible, of making sure that there is as much of a clean linkage as there possibly can to be to additional resources. And then fidelity, keeping our promises. One area that I think about in this space particularly is with our responsibility around confidentiality, which is extra important in the drug and alcohol treatment space. And I will give you more information on that if you are unaware of it soon. I already kind of hit on this a minute ago, thanks to a participant out there in the Zoom chat. Keep those Zoom chats coming, love it, because we are 930 of you out there, and I'd love to keep hearing from you. But as I already said, language does matter, and we have to be very aware of our biases. And sometimes our biases that come out when we don't necessarily mean, that's just changes in terminology. Used to say addict. I have taken that term out of my vocabulary, and if I do use it, I use it in reference to someone is using the term addict, or I do air quotes around it, because that's no longer the acceptable terminology. Person with a substance use disorder, regardless of what it is, I do recognize people's autonomy to self-identify in different ways that they are, particularly when we think about the overlay of our self-help groups and things like 12-step groups like NAAA, still very much common for hello, I am an alcoholic, hello, I am an addict, and that is how people identify themselves, and certainly people can self-identify however they want, right? But never a label I will give. Ethical responsibility, to reiterate this, primarily for our client or patient. I will use both terms interchangeably during today's presentation, most likely. But thinking about all those secondary or even tertiary responsibilities we run ourselves into, like the members of the person's family who is involved in the care, the spouse, significant other, mother, father, whoever it is, the employing agency, whether that's our employing agency as providers or the employing agency of that client who maybe referred them to us, the EAP, the union, et cetera, society at large, the profession, and then certainly ourselves as professionals, right? We all have responsibilities of when we are acting in a ethically sound manner. Ideally, all of these entities get served, but where we can run into friction, certainly you may have experienced, is when the interests of one of these parties outweighs or maybe gets noisier than another. Case example, my responsibility again to my client, I start getting phone calls from the probation or parole officer who is working with this client, right? And they are telling me I need to have all the information about so and so, and I look at my records very, very quickly, and I do not have a consent to talk to this person. My response is I can neither confirm nor deny. And entities don't necessarily like to hear that because, and I've particularly experienced this with legal entities, whether that's judges, probation, U.S. Marshals, whoever it is, they don't necessarily agree with my standpoint that I have to have a consent. So they give me some pushback, but I will be steadfast in my commitment to hold confidentially the privileged information of my client. Of course, in my mind, I'm then thinking like, okay, I'm immediately going to go talk to this client and say, hey, I want you to know that a probation officer is calling. Do they need to have information? And a lot of times those things get handled because the client often would like for other entities who were involved in their care to know about that. Some of this will come down to, did you ask all the right questions on the front end? And sometimes it's as easy as, is there someone else you would like to be informed about your care? And if so, how much, what, etc., right? And yes, a number of you are echoing exactly what I'm saying. You were probably already typing it before I said it, but absolutely, we must address it on the front end. And I will give some more information about assessment and kind of intake. Sometimes I have a little overkill viewpoint on it, but take what you need, leave the rest, kind of an idea. Okay. Okay, so let's talk about some infractions, allegations of wrongdoing. Here's a chart. It's a couple years old. Sorry about that. It is from HPSO, which probably represents a lot of our malpractice insurance across the room. If you do not hold malpractice insurance and you are in any way, or shape, or form providing care, even if you are a student or intern, please pick up some insurance. It is super cheap, even cheaper if you are a student. So got to get it. That's one of my top tips of the day. Okay. What are some of our common infractions? Number one, sexual or romantic interactions or relationships with current clients, clients' partners, or family members. And in this case of malpractice claims that HPSO was involved in, it represented 32% of claims. Some of this stuff, y'all, comes down to how provable it is, how easy it is to have evidence of some of these things, right? Some of the more nuanced things, can be a little bit more abstract, like potentially one of the things I'm thinking about is unprofessional conduct or things like that. Depending on what that overt behavior is, that can be a perceptional thing. People can make claims to the board of this person, didn't quite say the right thing, which I've certainly experienced in helping fields, but may not have a lot of substantive weight to it. Whereas some of these other things tend to have fire with smoke, right? So not practicing within your boundaries, pretty darn easy to prove. Somebody says you did EMDR care and they said, where's your EMDR certification or training? You do not have it. Hey, that's a pretty open and clear cut case, right? A number of these talk about multiple relationships, the improper sharing of confidential information. Again, usually a pretty easier to prove thing because somebody, another third party says, I got this email or this fax or whatever, the text message, however it is you're communicating about so-and-so client. They shouldn't have had that. Here's the evidence, open and shut, right? Here's some other common things to be aware of. Failure to meet continuing education requirements is often a reason why people face board issues. And that doesn't necessarily mean you lose your license, particularly not on a first infraction, but you might find that you have to do some mandatory CEs. You might be put on a provisional probationary state, depending on the board that you are operating with. Um, Dual relationships certainly can take a lot of different forms. We're going to talk a little bit about the multiple relationships from a romantic sexual relationship, as well as some of the other nuance of what that could mean. General unprofessional conduct, fraudulent billing certainly is going to get you caught up. And again, that's one of those pretty easy to prove ones. Counseling without proper credentialing and licensing. And then certainly there are other things outside of your actual clinical work that can result in disciplinary action. Whenever you go for a license or whenever you have to renew it, you have to give an attestation of moral character and answering questions about have you had any misdemeanors, felonious activity, or any things like that, as well as general harm to potential harm to society. So things like getting a DUI and then having to make sure you report that to the board. My tip on these kind of things is if you do face anything that is going to fall in the area where the board may take action on it, act early. Be transparent about what has occurred, what you are doing to rectify it. And in some states, there are professional wellness programs through the boards who can help to navigate through maybe some of the mandates that they may have for you in order to work through that situation. Okay, number of different things that you may face, up to including fine or loss of privilege to practice. Okay. Some general tips on avoiding malpractice claims or loss of license. Professional boundaries. Going to talk a number of things about that. Okay. Understanding what your state code says and stick to it. Here's a top tip for you. Go and print your state administrative code for your board, because those are things that are ever changing, and sometimes they add or remove things from the code. And if, let's say, for instance, you are operating under the code that is active today in 2026, and in a year you find that they've made a revision to the code one way or the other, and in that time a claim gets made against you, and it is somehow a nuanced case where maybe I was operating under this within these guardrails at the time, but now those goalposts have changed. You want to be able to go back and say, well, when the service was provided, this was the rules of the road, and this is why I did it that way. It might seem a bit of an extreme example, but I've certainly personally seen, as if you've been working in the field for any amount of time, codes and rules change, and keeping that historical record can be of value, because I can tell you, finding that stuff after the fact is going to be difficult, if not impossible, unless you happen to retain it. All right. This all just kind of goes in another general top tip I give to professionals, and particularly those of you who are newer in the profession. Make yourself a good, robust professional binder, okay? If you're still in school and you're joining us, make sure you're keeping all of your transcripts, your syllabi, course descriptions all organized. Once you start getting certifications and once you start getting licenses, keeping those up to date, keeping a copy again of that state code, keeping a copy of the ACA code. NBCC is another example for therapists. Social workers and marriage and family certainly have other examples. Keeping copies of all these things. You never know when you're going to need it. Relying on your email records is not a great place to go. And then you also get to put all your lovely, pretty CEs in there. That way, when your computer crashes, you're not having to backtrack over the last 2 years, which may prove ineffective or not accessible, right? Okay. Good comments. Keep the comments coming. Thank you. Keeping accurate and thorough notes. Well, I missed one, but I'll go back to it. Keeping accurate and thorough notes. Document what happens. We know documentation is kind of a balancing act of not too little, not too much. I'll tell you from my experience, I tend to not use a lot of quotes. Unless it is very, very pertinent. An example of something I might quote is the person says they are going to kill themselves today. That's probably quote worthy, right? And other things, I tend to be a little bit more generalized, where I understand what is happening here, but maybe not necessarily something that would be as overtly understood if I had to read that in front of judge, jury, and my client and all of his family, right? Going back one, managing client expectations, your informed consent. I'm going to give you some more examples of some specific informed consents of some things to include later, but informed consent, of course, has to be a living document. It is not one of those things that, hey, I'm going to get you to sign this thing and I'm never going to talk about again. There are opportunities where it organically comes out up throughout the course of care, but then certainly we need to make sure we are giving good attention to those as statuses change. Perhaps somebody has relocated. Perhaps there is a need to revisit parts of the informed consent because you find that they are sending you requests to be a friend on Facebook or something like that, and needing to go back and remind, hey, this is actually something that I covered in the informed consent, that we're not going to be social media friends, that we are not going to have a personal relationship, that this is professional, and here are the costs of the service. Because undoubtedly that can be an area of strife for people if they feel that they were misrepresented in costs or billing if they don't show up. What's your rule on no-shows? What do you give any leniency on that? Like a one-time, you can miss one time and I won't ping you for it. But guess what? You've got to be consistent. A lot of this again comes back to our principles around fidelity and doing the things we say we're going to do. Don't make exceptions for people. If you would not make that exception for everybody, you do not make the exception, period. What that looks like is favoritism. What it looks like is bias. What it looks like from the outside perspective is that you have a very different relationship with this person than you do all of your other clients. And I want to know why. Those are the kinds of things, and I'm getting a little ahead of myself. We're going to talk a lot about that in some of our later session with kind of boundaries and things like that. But those are things that, again, some of the things people are kind of saying in the chat here about, here are some of the markers about, this looks like that. The optics of this look like an incompetent or ineffective worker, okay? Okay, so terminating a client when they cross those boundaries. Okay, so again, not making those exceptions, and I'm going to talk about termination on my next slide. But this has to be something that is objective as possible, but also recognizing that fitness in our therapeutic relationship is a very important element that we have to continually reevaluate. Relationships in our therapeutic work can change over time, especially if you have long-term clients. You might find that you were very effective for them early on, but maybe you've got them to a milestone where you're no longer as effective for them as you potentially were or could be. And a referral might be very much pertinent at that time. So we have to have a bit of a ego check, as it were. You are not the end all be all therapist for any particular client. We all have our expertise and certainly lean into that wherever possible. But there are just some clients that you have to recognize you would struggle to work with in one way or the other. Maybe it's because of lack of training, maybe it's because of lack of understanding of that population, of that diagnosis or their needs, et cetera. So referrals are necessary there. I will go ahead and say one of the things I might say on my next slide as well, but I'll go ahead and say it now is you have to reconcile kind of the balance of that too, because I think particularly about if you're working in a maybe a more remote area, you don't have a lot of options for referrals, or if maybe this is an area of need that's not well cared for in your region. I would rather we enter into a transparent helping relationship, helping somebody, but letting them know that this is certainly not our expertise area, but we're going to do our own homework. We're going to be informed by what they're telling us and their journey. And we're going to work on this together for as long as we possibly can while it's being effective. And what I think about that is if you're working with a particular diagnosis or condition, where again, there's just not going to be a lot of other resources around, but you are better help than then having no other option. And of course, recognizing the fact that you're even talking to them was kind of a milestone for them that they were willing to seek out help. So we do not want to do is inadvertently, by through the referral process, say you're beyond my ability to help you. I can still help you, but maybe not as great as I could. But I don't have. There's not another option in town. There's not another option in our state. But we're going to explore those options actually as part of our treatment plan. And we're going to be transparent about what we need to do if we need to elevate this to maybe a higher level of care or a different specialist. Okay. Um, Okay, know when to, and I basically said that, know when to recommend to a specialist. Okay, proper termination. I want to talk about this. We've got to be aware of the culturally and clinically appropriate referral sources and be able to suggest those alternatives. I was already kind of talking about that. We do not refer people away based on our own personally held values, attitudes, beliefs, behaviors about that person, diagnosis, condition, etc. Right? Um, there can be a number of things said here. If you live in the state of Tennessee, I implore you to look into kind of what your legal code actually says about this and how that reconciles with ACA. But that is a different presentation for a different day. That's one of the ways I always adapt this presentation. I don't necessarily hit on all of the things I could say on every topic, but hint, clue, go do your own research on what that means in your state. Above all else, follow ACA is my recommendation. Um, we terminate the relationship when it becomes reasonably apparent the client is no longer needing our assistance. Where I think this is an interesting topic is for those of you who work in your own practice, and at the end of the day, service hours equal income in your pocket. Reconciling this notion with the practicality of running a business and having a livelihood that supports you and your families, to me, that is just rife for potential abuse. And I'm not necessarily saying a purposeful abuse, but a slippery slope, as it were, where I imagine that this could be very challenging. I've been again, working in an agency setting for 15 years, I do not hold my own shingle out. So I do not necessarily know all of the logistical hurdles that you all in private practice face, though I have enough colleagues who do that and I get input from them. But this is an area that I particularly find challenging and an area that I don't have to deal with because when I do and when I did provide direct primary care, again in an agency, I would often do group therapy, whether I have 10 or 12 people in my group, did not hit my bottom line dollar any different. Um, so that can be something to really examine for self on whether or not there is a potential abuse or the perception of abuse here. Okay. Um, let's see. We provide pre-termination counseling and recommendation. It should not be something that happens abruptly, certainly not. And often, if you look at the what the literature says about this is this actually comes in phases, and I think it's usually about 4 or 5 distinct phases of the pre-termination kind of initial exposure through kind of level setting on feelings and thoughts about this. And it's like a stage of change you have to work through with this. I wasn't really thinking we were going to be terminating, but okay, now I'm kind of thinking pros and cons about what this could look like. Okay, I'm getting ready. Here's what my plan is going to be. I know what my resources are. I know what I'm going to do if I feel like I need to come back to services. And I'm making my plan and all of those things as we kind of fold in the finalization of that treatment plan, right? Above all else, we do not abandon or neglect clients. And what you have to make very clear for your clients is, when does the relationship begin? At what point are we in a therapeutic relationship? Is it when you sign your consent documents? Is it when we've engaged in a pre-session dialogue to get you scheduled? Is it when I've done my first session or assessment with you? Arguably, depending on your perspective, it could be any or all of those things. When do we have this responsibility? Some of this is going to come down to client perception. And so that's why it's very important, again, in your informed consent to be very clear about how people are going to communicate with you, how they're going to reach you after hours or in the event of an emergency. Because if they have the perception that you have neglected them, they certainly have the right to make a complaint. And that's why I want you to have some of that extra protection at play as to what's written down in those consents, right? Okay, let's move into competency. Fun session. Okay, competency. I'm going to give you a definition. I want to give you some specific information on telehealth. This has been an evolving topic basically since COVID that I've been adding and taken away from. I'll spend a few minutes talking about it because I know it's relevant for a number of you in the room. I do want to spend a couple of minutes, though I could do a whole presentation on substance use disorder specific competency areas, and I very well might, always looking for different topics. Scope of practice, impairment, how we resolve some of these issues, and then our own professional wellness and impairment, starting with competency. I ask you rhetorically, please do not answer this question in the chat, but ask it of yourself out there in the room you're sitting in. What can you competently do? And how do you know it? And do you have any backup of what makes it that you feel confident that you can competently do it? Sometimes I ask questions about competency and people say, well, I hold a license to be a counselor. I know plenty of incompetent counselors. Sorry, not throwing shade, though I am. Having a license tells me you were able to enroll in a master's degree program, show up enough, pass a couple of tests, and file some paperwork. I don't know if necessarily that makes you a good, qualified, competent counselor. Um, so we can't rest on our laurels about a license, a certification, or whatever. Um, all that means to me is that in some ways you're more liable in the event that something goes wrong versus if you were practicing without a license, ironically. It makes you in some ways more responsible, right? That's again why we need to have standardization of requirements, management of infractions, which I know vary by situation, by board, by state, etc. There are case examples of people who have infractions who return to the profession seemingly with what some would consider minor consequences that maybe just don't reconcile with how I think we should be operating, right? But should is a weighty word. I'll try not to should all over us today. What are the boundaries of your competence? And again, going back to that ego check of, are you really going to set that boundary and say, this is beyond my scope. I need to refer. And at the end of the day, I know that that is going to free up a slot on my schedule and it's not going to get filled immediately. And that's dollars out of my pocket. Well, you got to do it, right? You got to do it. Okay. Let's talk about telehealth. In general, if you're doing telehealth, I really hope by now you've worked through some of the basics. I know COVID blew the doors wide open. We could kind of do Wild West stuff. That has retracted a number of years ago. You've got to be on a HIPAA compliant platform. You've got to know how to work it. You need to understand in a very general way how information is protected. You need to have a BAA with whoever you're working with. I don't always like name checking certain things, but simple practice or therapy notes or whatever those platforms are that are out there. You need to have a BAA with them. You need to have the proper documentation that protects you. It ultimately protects the client's information. If you don't know about that, certainly look into it. That's one of the reasons why we got to be using these HIPAA compliant platforms is that places like Google, Google or Apple, if you're using FaceTime, Apple's not going to do a BAA with you. That's not what they're going to do. Same thing with like Google. It's not going to work like that. If you're using a platform such as like right now we're on Zoom. My organization uses Zoom for healthcare. We have a BAA with it. It goes through the rigor of the high tech requirements under HIPAA. Lovely question. Thank you, Megan, for asking it. BAA, what's a BAA? Sorry to use terminology if you don't know it. Happy to explain it. Business Associate Agreement. It is between the two entities that basically says you're going to do right by protecting the information that's out there in this virtual world, and I'm not going to break any of the rules that you set as an operating site or operating platform, right? Okay. Here's some specific things. If you are doing telework today, if these are not in your informed consent, I really want you to consider them. Okay. Um, Defining what telehealth, telecounseling, how we work on this platform in your informed consent, how people can expect to work with you, right? You got to identify your platform. We are using Zoom for Healthcare. This is how we are going to communicate. We are going to communicate on my Calendly, whatever the heck it is built into my EHR, that you can send me messages and you can get on my calendar, and we're going to use email, but we're not going to use text. Or maybe you choose you are going to use text. Okay, cool. What are the rules around texting? I need to know the specific number. I need to know what the hours you can expect a response from, right? Um, Risks and benefits of engaging in the use of telehealth services. We should be consistently evaluating, is this person appropriate for being served via tele? Because certainly there are some folks, some conditions that are going to be better served in person. Some of this might just be personal preference. Excuse me. Person doesn't want to be on Zoom. They don't have to be on Zoom unless you are only a telehealth provider, at which point you got to make a referral, right? But ideally, they figure that out before they have even met you. If you are advertising on Psychology Today or any of these other kind of, if you have your own website, wonderful. Hey, make it really clear how you operate, where out of generally you operate. And if you are doing, hey, some sessions are tele, some of them are in person, I do them different days. Hey, cool. Like just go over that in the beginning, right? What are you going to do if technology fails? What's your blackout plan? We've had widespread internet outage, powers out. How are we going to, one, get in touch with each other to coordinate, hey, we're going to reschedule this, or can we back this up to another way of continuing our session? Maybe go to in person if tele doesn't work, if we're in the same geographic area, great. But what are we going to do before the session happens? But also, what happens if I lose you during the session? Do I have the means of getting a hold of you? Email, phone number, text message, whatever it is. Very important. Are we reviewing at this time our boundaries around social media? Because what's happened, in my view, is as we've all kind of gotten more comfortable working in a virtual world, it's right next door to, hey, my Facebook is, I deal with my Facebook on my phone too, and I deal with my counselor on my phone now too. I'm just going to go ahead and friend them because it's like we've merged concepts that used to be a lot better partitioned. And so we've got to really hit hard the social media policy that you particularly have for how you operate, right? I went over emergency procedures in general, but one of the more pertinent emergency procedures is, do you know where the person is at the beginning of every session that you do with them? I know you probably have in their case record their home address. Great. But is that where they called you from on that random Tuesday morning when at the very end of your session with them, they said, I think I'm going to go kill myself. This has been lovely. Goodbye. And they hang up. Where are you going to route emergency services to? That's why at the beginning of the session, you ask them whether they're sitting at home or whether they're sitting in the McDonald's parking lot, because that's where they can get Wi-Fi connection. You figure that out. Someone else has already pointed that out. I think they even posted that before I said it. So thank you, Laura. Great call out. You got to discuss the cultural and language differences. preferences, maybe a better word about providing telehealth services. Certain individuals, for various reasons, don't like tele as much as other. I think we might be able to draw some generational characteristics here. Perhaps younger people are more inclined to engage in telehealth services, whereas people who are not as tech savvy or tech comfortable might be put off by this whole idea. Okay, meet them where they're at. Like, what can we do, right? When I think about like language differences, I think about the fact that sometimes I can struggle to understand people more virtually than if I'm sitting in the room with them. And that's just my own ear that I find that sometimes it's harder to understand people, particularly if they may have a dialect or an accent. So think through some of those potential barriers. And again, it might go both ways. It might be you as the helper, they're struggling to understand you. And some of that is you got to make sure you get decent enough mics, decent enough equipment, yada yada yada. And sounds like maybe some people even are hearing me a little bit muffled today. Sorry if that's the case. I have no recourse to fix that. Hopefully, it's not a widespread problem. Going over financial policies, is your rate for tele the same as in person? Probably. Um, does the insurance cover both tele and in person? There was and is to a degree sometimes still a variance on some of that, where some payers are not covering the service, and if they are, they even potentially are doing a lesser rate for tele. I'm understanding, not necessarily widespread, but some I know do. What are we going to do if you need to contact me and we need to pivot immediately for a different plan? But this also brings up a wider need of what happens if you become incapacitated for a longer term or potentially become deceased. I know you might be thinking to yourself, well, if I die, like kind of not my problem. Do you have a backup plan? As in, have you ever approached another colleague in this space and said, I'm going to give you my kind of break the glass emergency access so that if I die, you can access my client's information and you can communicate to them and say, hey, this person's no longer with us. That's why they missed your session yesterday. I want to make sure either I pick up care with you or I get you referred to someone else. Again, I think you might be sitting there and being like, okay, not my highest priority today. Okay, fine. But to me, that's one of those like appropriate caretaking things that we should do. Should, again, I can't believe I said it again, but it is something that I think makes for a quality, conscientious professional, is if you have thought through these things and made contingency plans that above all else are putting your clients in the forefront of what your intentions for care are. Okay. Um, and okay, I think enough said on that slide, right? Okay, let's talk about substance use disorder competency. Okay, this again, this whole slide could be its own presentation, maybe for another time, right? But here's what I want to challenge you about as a practitioner out there in the world. Again, noting the drug and alcohol might not be your forte. You might not interact with those with substance use disorder on a daily basis in your work, but I guarantee it, they're in your rooms, they're in your offices, they are there. And if they're not there, you're going to need to expand your assessment a little bit more. Are you generally enough aware about common drugs and trends out there so that if somebody used um, some nomenclature you're not familiar with, or they disclose to you that they are using a drug or perhaps are on a medication, that you have enough familiarity that you can at least fake it till you make it, that you know what you're talking about, right? So, you get a new client come in who, you're going over their history and they disclose to you that they are on buprenorphine. Okay, do you know what buprenorphine is? Do you know probably why they're on it? That allows you a jumping off point to ask some additional questions in understanding their history. That very well might not be the reason they are in care with you that day. They are coming in for anxiety and kind of transitions in life, things that they're dealing with at home. But the fact that you now have this window into a little bit more of what is going on in their background makes you for a much more informed provider of care. Um, if somebody uses lingo around a drug that they used, listen, I can't keep up with all the lingo. Most people in our space, I think objectively cannot keep up with all the lingo. It's always okay to ask clarifying questions and not be the expert all the time. Good thing. To ask, can you clarify exactly what substance that is that you're referring to? And then kind of generally at least knowing, okay, that's going to fall into one of these categories. I generally know how that works, right? Because you got to be able to make intersections with these things. Somebody is using a stimulant. Let's say they're taking Adderall. Let's say it's prescribed 100%, and they're coming in with anxiety. It's like, well, maybe those things could be chicken or the egg, one causing or correlative with the other, right? So, kind of understanding some of the psychopharmacology elements here and how we connect that with diagnosing and assessing is very, very critical, right? Do you know what to look for if somebody is intoxicated in your office? Are they nodding out? Do you know what I mean when I say nodding out? Do you have Narcan in your office? If you do not, seek out Narcan. You can buy it over the counter nowadays. If you're not going to run it through your personal insurance, you do pay for it. Last I checked, when I went to Walmart, it was like 70 something bucks for 2 doses. But you can also, depending on your state, you can get it for free. I don't know what state you're in, but Google free Narcan in my state. I know, again, state of Alabama. The Alabama Department of Mental Health has a program where they will ship this to your house. Yay for Alabama. Thank you, Laura, for pointing that out. Thank you very much. Okay. Medications, again, as I mentioned, buprenorphine. Are you aware of others? I mentioned earlier naltrexone or Vivitrol, methadone, again, being one of the kind of long-standing medications for treating opiate use disorder. But are you generally aware of what that is? Excuse me, and how they work? Are you aware of co-occurring mental health conditions and how those intersect and interplay with drug and alcohol? Suicide risk is a correlation with drug and alcohol. So if you do any digging on this one, which I encourage you to do, don't take for granted that because someone is sober in your office today, that they are in a lesser risk for suicide. Sometimes risk for suicide actually goes up as people begin working their journey of recovery. So while acute intoxication is certainly a risk, particularly if there are firearms involved or a means which has carries with it a high level of lethality, we know that drugs and alcohol can certainly propel people into that behavior, but let's never lose sight of the role that the drugs and alcohol have in suicide, as well as what even sobriety can mean for folks. Are you aware of cross-addiction behaviors as, let's say, you start your journey of working with somebody who is beginning early recovery, and the fact that some of these behavioral mechanisms might show up in other things, such as compulsive food eating, shopping, um, excessive exercise, if we want to put kind of a pro-social view of it, and then sex or relationship addictions. Basically taking one addiction and replacing it with another so that the dopamine hit continues on a very basic level. When we talk about Freud, which I don't want to spend a lot of time talking about my mother, sublimation was one of my most intriguing defense mechanisms, as it does carry with that everybody thinks everything's looking great. And wow, we're really happy that they're getting healthy and they're exercising and all that stuff. It's like, yeah, but are they going too far to that end? Is it really still just a way of blocking out reality on reality's terms and using that as its new escape, right? Which one would the family rather have? I can usually tell you, but then they start getting angry that the person's still never around because that they're at the gym. They're not at the bar anymore, they're at the gym. So I think there's a nuance to some of these things. Oh, and of course, someone pointed out, how could I forget, gambling as another often replacement. And while I mentioned sex and relationship, pornography as another one. So there's definitely a lot of cross section with this space, which I love. That's one of the things I like about working in this space. There's so many interesting facets we can go down. Are you generally enough aware of family dynamics, family systems, and how those are certainly not only propelled in a way, sometimes into substance use disorder, but then how the system is reactive to the disorder itself, and all of the fun nuances we have with family relationships and family roles. Lots to be said there too. Recovery resources vernacular. Do you know where to send somebody if they are sober curious? Hey, I'm thinking about changing my relationship with alcohol or drugs, but I don't know where to go. Certainly, you can be of an assistance to them from whatever therapeutic perspective you are bringing to the table. Cognitive behavioral therapy, dialectical behavioral therapy. Fill in your treatment plan of choice. But do you know, hey, there are 12-step meetings, there's self-recovery, there's celebrate recovery, there's fill in the blank. There's a number of different resources, um, some of which may be more appetizing for different groups. People get hung up still today about not wanting to do the God thing in 12-step meetings. Smart recovery can be a resource for that. There's lots of different ways to skin the cat, right? There's lots of resources, all right? Scope of practice, I asked you earlier to rhetorically ask yourself what you're competently to do. This very much goes hand in hand with that. What is your ability or skill level? Again, me personally, I believe I have an ability and skill with working with those with substance use disorder. There are areas that I have not directly worked with in quite some time in terms of diagnosis or presentation, where I would feel completely out of my element. And I would be relying on colleagues and referrals for that. And that's how we all have to live and work together as a treatment field, as practitioners in this space. We have to rely on each other. Okay. Training certification, go get them. Keep it going. Keep adding to your collection, as it were. I like to think trying to be pragmatic as well as purposeful in how you go after some of these things. What's going to be the biggest element of assistance for clients? And I think arguably right now, the greatest area that I'd recommend practitioners go after is EMDR, based on what the research is showing us around how elements of that can be added to not only long-term, but even a short acting treatment regimen. So if I was going to be recommending where people go to get some additional resources, that would be the approach of choice, I think, at the moment. Continuing education, certainly never ending, but do not take for granted that just because you've got some continuing education by watching a couple-hour Zoom meeting on something, you're now qualified to go out and do it. Recognize your barriers regarding diagnosing versus being able to assist. Different states have different rules about what these mean. I'll give you an example. In the state of Tennessee, there are LPCs and there are LPC-MHSPs, which is what I am. That means you had to take an additional test. Means you had to do some additional coursework and the ability to diagnose clients. Whereas an LPC in the state of Tennessee can only assist. And it is a scope of practice consideration that you would not want to get yourself in any hot water by misrepresenting what you are capable of doing based on your license status. And then we're going to talk in a minute about impairment and knowing our own limitations with where I am impaired one way or the other. But I do, before I go into impairment in more detail, I want to call out kind of a bulletin, in this case from HPSO from a few years ago. This is about defining your role and differentiating, in this case, between counseling and life coaching. And I know that there are those who are kind of holding both qualifications. And in this case, that was what occurred in the matter that had to be decided on by our liability insurance carrier. And basically comes down to how are we representing ourselves and how do you know which hat you're wearing and how does the client possibly know that too? Um, there are considerations and limitations around who is responsible for regulating these various professions and what the codes or lack of codes say in some of these cases. And in this case, because HPSO was involved, is does your liability insurance cover you being a life coach? And if you are holding both credentials, you may want to very much make sure that you are dotting your I's and crossing your T's about what and when you are offering as far as services. I do want to spend a couple minutes talking about impairment because I think it's a very always pertinent topic. Straight from the code, counselors monitor themselves for signs of impairment from their own physical, mental, or emotional problems and refrain from offering or providing professional services when impaired. That is right from ACA, right? Um, Impairment. How the heck do we define impairment, though? Well, I put it on the slide for you. It's a significantly diminished capacity to perform professional functions or duties, right? But that can look like a lot of different things. A lot of times, particularly because of the vantage point I'm coming from, I hear impairment, I think under the influence of drugs and alcohol. But that's not the only example of impairment, right? It might be that you're dealing with physical pain, you're dealing with emotional pain, because you're going through something on a personal level, and that is taking you away from your ability to be um, present and to be acting in your full capacities in your professional duties, right? So we have to refrain from this, but again, where the rubber meets the road operationally, it's like, well, does that mean you'd never provide counseling services to someone when you're feeling under the weather? Like, I'm sure I know that that happens. I've gone to work sick because I know plenty of people have. Maybe in the post-COVID world, we're a little bit more cognizant of that and we do a little bit more masking up, things like that. But as someone in the chat is saying, yes, keep the chats coming, it can be very, very subjective. That's my point. This is very a subjective framework from the ACA, in my opinion. Um, we have to do a quick gut check on self. I also say we got to be looking out for others and recognizing impairment that might be impacting them. I don't want to give too many details or go too long down the case example, but I know for one example that I was personally involved in, I needed to remove a colleague a number of years ago from their ability to go into a group therapy session, not because in this case drugs and alcohol, but because they were dealing with a very stressful family situation that was very, very fresh, and they had lost their ability to really be present. So it was, hey, you need to get out of here and take the day and call me in the morning, and I got you covered. And then we'll get in there and take care of your clients, yada, 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 right? Much easier to talk about and do in an agency setting versus if you are out there on an island, right? ABEC, this is from Alabama, so not if not applicable to you, don't overly read into it if different from your state code. But I wanted to compare a state code on this concept because while it certainly mirrors a number of things ACA is saying and being aware of our physical, mental, or emotional problems, this talks about refraining if there's a likelihood to cause harm or or likely to harm a client or others in this case, right? So it kind of puts that added phrase on it about like, well, I might have a minor impairment, but if it's not likely to harm the client, I feel like we could talk ourselves out of this one a little bit too easy, right? But again, I then say there's a bit of a better description if you read on. When your professional or your personal problem, excuse me, or conflicts may cause harm to a client or others, a little bit more specificity, right? We got to be alert to our own impairment is the takeaway here, and you got to be looking out for others, and then that brings us to how we might have to resolve some ethical issues. So if I notice that there is potential for harm for others, ACA says that if I believe that another counselor is violating or has violated an ethical standard or is impaired, uh, looking to the substantial harm that has not occurred, I would attempt to first resolve that informally with the other counselor if feasible. That's what the ACA says. But again, looking to my state code, it says if I suspect an ethical violation by other licenses, which again, we could fold in impairment as a concept, it says I must report the suspected violations to the office of the Alabama Board of Counselors, right? Unless it conflicts with confidentiality. Okay, fine. A little carve out they gave to protect themselves, I guess. So it kind of creates this balancing act, in my view, about okay, on one hand, I might have an inroad about, okay, I think you're temporarily impaired, and here's my feedback to you on that one, and maybe I can help you resolve it, like I gave in my example about working in an agency with somebody. But to think about it broadly, and it's particularly if I suspect that a violation has occurred or there is potential harm to someone else, the responsibility to report that to the responsible boards, knowing that there are, kind of whistleblower protections in that um, if I am incorrect in my assessment, no harm comes to me. I can't be turned around and like sued by this person, et cetera, much like how child abuse reporting works. And knowing that I might have to participate in any kind of investigation with that, I go into that knowingly, and I will not use that as a reason to not report, right? Okay, let's go a little bit deeper on impairment, a little bit deeper, and then we're gonna take a break here in just a few minutes. Bear with me. Let's talk really broadly about burnout, compassion fatigue, and secondary traumatic stress. Burnout, it's an ICD-11 condition, though you cannot get workman's comp for this one, so don't even bother to try. It is known as a occupational phenomenon in the diagnostic code, right? Feelings of energy depletion or exhaustion, increased mental distance from your job, feelings of a negativism towards one's job, reduced professional efficacy, and it's not otherwise explained by an adjustment disorder, mood disorder. You may be sitting with me here on this call right now and going through this short list and going check, check, check as you think about your job, right? Burnout is an imbalance of demands and resources. There is not enough time in the day to meet all of the needs. There is not enough resources, whether that's money or mental bandwidth or whatever, to serve everything that we possibly could serve. So within that, we run into this scarcity situation, right? Um, Burnout is situational. It is not reflective of the individual. It does not mean that, this person couldn't take it, that's somehow a moralizing of saying that their character was impermeable to these risk factors, and that others, are doing better with it. And why can't you do better? I'm not getting into that. This is a reflection of the machine, of the system, the grind. We live in a modern capitalistic healthcare system that is a grind. Okay. And it defaults to no versus yes. And it is a lot of work. And there are not enough resources to meet all of the demands. And anybody working in this system is subject to burnout at any given time. And it can be that you experience burnout now, but can work to come back from it. It is not a one and done situation either. Though I will say, I believe, I have no research about this, but I do believe that once you start kind of living in that grind, your threshold tolerance levels are impacted, so that maybe in the future, unless one can find a source of resilience that is sustaining, you very well might be more subject to burnout, but also maybe other things like secondary traumatic stress or compassion fatigue in the future. All of these things kind of constellation working together. Um, Not going to read you all the phases of burnout. You're going to have these in the slides you can look at later. Compassion fatigue, I'm gonna put as we are out of cares to give. And sometimes I change the word cares to other things, but we are out of cares to give, right? I'm unable to be there in a compassionate, empathic manner because I'm just at my I'm out of gas, right? I like the analogy of we got to put the oxygen masks on ourselves first in order to help others, right? There are some cross sections of compassion fatigue and burnout, a lot of comparison here. Compassion fatigue, though, we're going to put more about we're fatigued because of our exposure to the work, to the experiences, to the being present and on all day, right? And it just wears and wears. That's why it's like if you're maybe more like me, you at the end of the day, you don't want to process the day. Like I've done enough processing. I've lived in processing all the day. I want to just put it behind me, right? Others among us need to go home and in general kind of work through the day. Certainly not giving confidential information, right, or patient identifying information, but need to kind of process and digest that, right, for our own good. Um, so again, comparison, burnout, system, compassion fatigue, very much specific to the work and our caregiving tendencies. Compassion fatigue tends to be more sudden and acute, whereas the burnout is just the gradual wearing down of the machine, the pistons working overtime, right? Secondary vicarious trauma, also known as secondary traumatic stress, also known as vicarious trauma. That is the exposure, whether firsthand or secondhand, to something that is shared with you in the relationship of the therapeutic relationship that is now impacting you firsthand. So, having what looks to be stress induced disorders of sleep disruptions, intrusive thoughts, fears, avoidance of going back into the rooms, or nightmares, things like that, right? So, there's lots of things that one might experience maybe because you heard the story or you kind of vicariously were experiencing in the moment the trauma that that person was sharing with you, that you started carrying it with you, right? So all of these things very much interconnectedly. As colleague Tamara Reed has pointed out, the Pro QOL questionnaire I will point you to as a resource. Please think about accessing this. It was still available last I checked. It is a 30-question self-report assessment that will look at compassion, satisfaction, burnout, and secondary traumatic stress. For supervisors out there, put this in your arsenal as a activity you can do with supervisees. I think that that is sometimes fun to do. And in supervision, I personally have done it where I will take it along with my supervisee and we will compare and we will talk about what does this mean about me and what does this mean about you in this moment now, and I think it kind of normalizes that because they're going to see it's like, oh man, my supervisor's a little burned out too, like it ain't just me. So I think it creates a good open dialogue about this concept within our profession, right? I'm going to actually leave this on the screen, and we're going to just going to take a 5-minute break. So it is for me, it is 10:41 Central Time. I'm going to come back and talk at 10:46 Central Time. That'll just give you a couple minutes to step away, stretch your legs, and I will see you back in a moment. Thank you. Buddy, I know a couple of you in the chat are wondering where we went. We are on a break, just for another minute or so. While we are on a very brief pause, if you would want to send a question my way, if I have perhaps overlooked it, I'd be happy to give you some attention there. I do want to address someone in the Q&A asked a question about an overlap with the concept we were talking about with harm reduction approaches and compulsive behaviors. Um, I'm again not an expert on what I'm assuming compulsive behaviors might be, like obsessive compulsive disorder behaviors, maybe things like that. But my understanding is absolutely yes, that progress is always the goal versus perfection, and that If the person's goal is to reduce the compulsive behaviors, taking strides in order to meet that is always going to be a focus, and that let's not let perfection be the enemy of that good. Someone has asked, what time does this end? It will end in 1 hour and 14 minutes. Um, what resources do I have for people, excuse me, adolescents to help with substance use disorder? Well, that's actually a hard one. I worked with adolescents for a number of years, and there are not enough providers out there in the world, regardless of setting, whether that's inpatient or outpatient. I don't always like using this platform as too much of a commercial, but on an outpatient level, my organization in the state of Alabama and Tennessee does offer IOP services for adolescents. Those are done virtually. Again, because there's often issues of just not enough people coming forward looking for treatment or able to access treatment. So being able to do consistent in-person sessions does become a bit of a barrier, sadly. But today we do offer telehealth services in those two states. Okay, I'll give another 30 seconds or so to any questions, and then I'm gonna get going again. Hopefully you all have had a break and have come back and you've refreshed your beverages and feeling ready to go for our remainder. Hopefully my voice will keep up. I keep taking lozenges if you wonder what I keep taking. Can social workers get certified with adolescent substance use? Not a social worker or expert in that area. I would imagine there's an equivalent. I certainly know that some states drive certification and like a certified alcohol and drug counselor type scenario. I wonder if maybe you could hold both. Be a social worker and hold that's like what I know the term CADC. I don't know if that's limited to therapists, so you might want to do some Googling. Very much so. Also, there might be somebody who here has that answer. That's the other good thing about asking these questions in this forum. Someone else might know the answer. I don't want to be the expert on everything. Because I ain't. You can ask people I work with. I ain't. I will refer to the subject matter experts. Okay, let's talk about confidentiality. This is everybody's favorite topic. We're going to go through it pretty fast though. So if it's really not your favorite topic, no worries because we got to make up a little bit of time. I'm going to talk about confidentiality from a couple of different perspectives. HIPAA, which certainly is applicable to probably everybody on this call, and then 42 CFR Part 2, which is specific to working with the drug and alcohol population, with some interesting caveats I'll tell you about in a second. There has been updates in this space, not as much in just the last year, but if you haven't watched this course in the last few years, definitely changes since about 24, 25. I'm going to go over some exceptions around confidentiality. I'm going to give you a couple case examples, get on a soapbox one or two times, and then we'll move on to the next section. Okay. We get into some sticky situations, to use a technical term, when we have questions about confidentiality, when we're trying to hold two things at the same time. We're trying to hold privilege and in holding that confidential information of our clients, but we have competing priorities, whether that is we are needing to disclose that information elsewhere, maybe in the case of a child abuse reporting situation, or we are worried about their own health and safety, so we need to involve emergency services for one reason or another. Or we are being asked to provide information by a third party entity. Take case example, judges, lawyers, whoever it is that is wanting certain information for whatever their purpose is, right? General statement here is that we protect from unauthorized disclosures of information given during the therapy within the therapeutic environment. If we hold to that principle, we are doing pretty well, and we will use that as our guidepost moving forward. We got to, take reasonable steps to secure that information. So I gave information earlier about telehealth platforms, so compliance with HIPAA and the high-tech law. If you are using a HIPAA compliant platform and certainly are entering into that BAA, as an astute observer in the chat earlier noted that that is actually a requirement of HIPAA, and they are correct. then you are doing your due diligence on that one, right? But I want you to think about filing systems. Not so much stuff's probably on paper anymore, but you're keeping stuff in the cloud probably. Where's the hell does that cloud go? Keeping different personal computing versus professional computing files, right? It can be one example we go in. Social media, also, having a different social media presence for personal versus your personal your practice, I should say. So there's bifurcation that has to happen. We got to keep the edges clean, right? Best practices, you will have that professional platform, BAA, written authorizations for information that is disclosed. And recognizing that technology is something you need to learn enough about to be dangerous. So being on secure Wi-Fi, if you're using Wi-Fi, if you're doing practice in kind of a more open space, making sure people can't hear you, earphones, if you're around other colleagues or whatever it is. This also goes for your recipient. So you have a client who's on the phone. Is there anybody in earshot of you? I don't necessarily want them to hear you if you do not want them to know what you are saying. Do we need to have a safe word so that if very quickly we need to stop talking, change subjects, or you need to disconnect, I know that everything's okay because it's your spouse is coming in and you were talking about them, and we need to do something different here in this situation, right? Someone else has pointed out noise machines is a good option. Yes, certainly have things like that as a good tool for your trade. Talking about two things: HIPAA, Health Insurance Portability and Accountability Act, 1996, and the 42 CFR. CFR means Code of Federal Regulation Part 2. It is the federal law that regulates protecting information for drug and alcohol, which includes treatment and assessment and prevention. HIPAA, again, since 1996, it's has a lot of aspirational elements to it. I'll say administrative simplification. Hopefully, would have some kind of cost comparison when you look at HMO administrative fees, but also procedural fees, so that there's kind of a checks and balances within the systems. It does for our, kind of where the rubber meets the road for our purposes. What it really does is it protects that patient health information, PHI, or protected health information, I should say. Protects it no matter how it's transmitted. It gives information about how we as clients and our clients can access our PHI, how we can get amendments or corrections made. And again, it does have some aspirations of kind of balancing the cost of care, because within these large HMO systems, if we know that a hip transplant over here costs X amount, but within the same hospital system, it costs this amount, it would hopefully level those and equity in that, right? That is regulated by HHS, the Health and Human Services Commission. Names change from time to time, right? 42 CFR. Again, I said it's for drug and alcohol. Some people say, well, I don't treat drug and alcohol clients. An agency might say this even. If federal funds are accepted, or if there is a prescribing of MOUD or MAUD, buprenorphine, Vivitrol, things like that, that puts you on the list as quote unquote being federally assisted. So sometimes programs try to get sneaky and say, well, we don't take any insurance. So no, none of these things are federally assisted, right? We're not getting any grants, yada, yada, yada. Well, hey, do you do buprenorphine? It's actually applicable to you. So if you did not know that, now you know. The idea behind these rules, and these rules predate HIPAA. These were from the 1970s, is to reduce the stigma of people to seek care for drugs and alcohol, right? Because they know that their information is going to be protected. The debate then comes in, on one hand, by overly partitioning. Okay, we got medical and mental health records on one side, and we got drug and alcohol records on the other, and we don't bring these into to use the word of the acts that have come in more recent times, kind of a parity, we're treating them differently. And on one aspect, as a provider standpoint, we're not necessarily getting access to the full informational picture, right? Um, with more recent legislatures, such as the Mental Health Parity and Addiction Equity Act and the Affordable Care Act, most significantly, we have aligned that a condition is a condition is a condition, regardless if it's mental health, medical, or substance use, right? So all of them, on one hand, should be covered, is what the ruling has effectuated. But then the other aspect of it is then how do we continue to reconcile this with what the aspirations of Part Two are, and why SAMHSA, the Substance Abuse Mental Health Services Agency, continues to have the position that we must have a different set of rules for drug and alcohol protected health information, because perhaps in their view, the weakening of protections may result in fewer people seeking treatment. Don't know, could be. I don't think it's well researched or tested, frankly. Because over the last couple of years, there has been increased momentum to adopt these changes. A lot of this really propping up during COVID, the CARES Act, which was basically a Christmas tree act, which they hung everything in the world on, including some of this legislation. So, which basically pushed alignment with HIPAA. And some examples of things we saw with that: perpetual consent, meaning a consent doesn't expire in 1 year or 2 years, it goes on. It changed penalties of reporting. So on one hand, if you violated HIPAA, HHS through the OCR, the Office of Civil Rights, would come after you and give you fines, whereas Part 2 violations done through SAMHSA had, let's just be fair, no teeth at all. Penalties were non-existent, and even though they proposed potential criminal penalties for violations, there has never been a case example where that ever actually happened, right? All within this kind of tying in a nice anti-discriminatory language, lip service in my view, but I digress. In August 2020, they expanded for some emergency examples. Again, think August 2020, we're in the middle of COVID. What are some things we're allowed to maybe talk about for the purposes of, we're having to close down this treatment facility because we're on isolation because of quarantine? How do we coordinate that among different agencies, including local health departments, things like that? So kind of needed let's look at how emergencies are better characterized to be more realistic about how we need to share information for patient safety. Part 2 changes again, 2024. We have a alignment with HIPAA with a TPO, single consent. TPO has always existed, or at least as far as I'm aware, under HIPAA, where it is a consent where you are allowed to speak about relevant information as long as it relates to treatment, payment, and other healthcare operations. Now that is applicable under Part 2, meaning I might get a TPO consent, and you tell me, yeah, you can talk to my PCP, you can talk to my referring agency, and you can talk to my employer, all kind of under one large umbrella. There are carve-outs if it is related to civil or criminal legal aspects. So if it's a probation officer, court, even to a degree, if I'm recalling EAPs and things like that, you would want to seek out a different type of consent. Accounting of disclosures has always been under HIPAA, and if you've been operating like that, no real change. We are allowed covered entities and business associates receive the information kind of still under that same umbrella with lack of segregation being required. It aligns the breach notification, so if a breach notification happens, you're basically telling one entity, which in some ways makes it easier. They added a term, substance use counseling notes, but to me, I liken this exactly to psychotherapy notes, which have always kind of been a thing. So that still continues to be a carve out, differentiation. A lot of this stuff really started kicking up in 2024 and then went into effect just a couple of months ago in February 2026. 2025 changes, major overhaul specifically to cybersecurity requirements. And this is some pretty heavy stuff. And I really want you, I encourage you to do some exploration for this, particularly if you're representing yourself as an agency. because this is where I really think we're having some overburdensome legal requirements on one hand. On others, I certainly understand it and support it. But having asset inventory, meaning like computer systems and servers, and having a good understanding of what it is we're doing a minimum yearly risk assessment on our cybersecurity, having contingency planning, but the law says you have to be able to restore data and be back up and running in 72 hours. That's a pretty heavy lift. That's a very resource heavy proposition. Vulnerability scans every 6 months, sure, makes sense. Penetration test, as in you actually test somebody trying to hack into your systems every 12 months, makes sense. And just so much more. The thing is, if you're operating as an agency that maybe is resource light, this takes a lot of resources proactively in order to comply with this. And one of the things that we are seeing is increased OCR activity over the last couple of years, where many infractions are actually coming down to failures to comply with the new cybersecurity requirements, even if the infraction was limited or arguably fairly minimal. This is one other thing that which they can throw the book at an organization for. And pros and cons. I mean, I definitely, we are a very cyber rich world. There are definitely risks, and we must protect those risks. But there's kind of a reasonable operational test that we have to put this through, in my opinion. Okay, disclosure rules. Hey, here's the thing: get a darn consent. Get a consent in writing unless an exception applies. That's what these slides say. I know there were more words on there, but I'm going to try to go quick. Here's some permitted disclosures. Somebody has a medical emergency. You've got to do child abuse neglect reporting. If there's a crime on premises, that's a carve out. You have to again think about what is the operational aspect of this. Someone is pointing out there are some different sets of rules for military. There are. You're very right. Internal communications among team members, interagency, things like that. Among qualified service organizations or those with whom you have BAA, there is often going to be a sharing of information depending on relevance. Of course, that could be your EHR provider. It could be the contractor you use to come and do yoga with your clients once a week. They might be you have a BAA with them versus bringing them on and making them a true contractor or employee, things like that, right? Excuse me. Outside auditors, communications that don't disclose information, such as general statistics, vital statistics, things like that. And then research, which I'm not going to go into a heavy degree on research. That has its own set of ethical codes and rules and in considerations, and CFR regulations as well that you would need to be aware of. Let's think for a few minutes about what if you're unable to give consent. And there's a few examples that come into play with here. I'm going to talk specifically about minors, but it could also be those in a guardianship or a litem situation. But when talking about minors, you have to be aware of what the state code says as to what age they can consent to entering into a therapeutic relationship. And by the way, that can change. So always be up to date on that one. We always seek the assent of that minor client we are working with. So they're at least maybe sometimes reluctant buy-in to work with us, and knowing that they are protected under confidentiality and that I'm going to do everything I possibly can to uphold the privilege of the information that they give me. Knowing in practicality, as this slide says, there are truly some legal issues there, limitations, better word. There's a quote that I often use when I talk about this topic: confidentiality exists for the benefit of the client, quote, even if he or she is a minor. That's what this quote says that I found long ago. I would add to that, especially if they're a minor, especially if you work with young people. Here's one of my soapbox. I have a couple. This can be a make or break opportunity to work with this population. And if we do not do a good job working with this clientele, if they don't trust us, if they look at us as just another arm of social services, the DCF, DCS, or their probation officer, if we're just a administrative tool for the school, whatever it is, they may never seek out professional services again in their life because they will have this view of how they were treated whenever they were young people. So there's a level of autonomy they absolutely must be given. There is a level of respect that they must be given. They are not just the subject of the client who is their parent or guardian who's paying you. That's not how this whole thing works. Okay, and I know that sometimes we get ourselves into those situations where there is that request for information from the parents, from the guardians. That's why I'm pointing these things out to you on these slides about our role of advocacy and being upfront with who those third parties are, parents, guardians, whoever it is, grandparents, yada, 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 to this is how information is going to be shared. This is what you can expect from me. And if I am not the clinician for you, we will not go down this path. You head this off at the very front of informed consent, and you make it very clear. And you do have legal precedent behind you. I have those on the slides here about what is called circumscribed information. So I will share with the family what is relevant from a safety perspective, from a general care update, but I am not going to get into the weeds on exactly what my client said. We don't do that with adults. Why would we expect to do that with younger people? Okay. I do want to call out, as I do, some changes that have happened. This is one of our Alabama more recent changes. As someone pointed out in the chat, they threw out age of ability to enter into the helping relationship. In Alabama, historically, it was age 14. It is different in different states. In Tennessee, it used to be 16. I don't actually know if it still is. Whereas at first they wanted to move it in Alabama to 18. They then made a negotiation and they changed it, compromise, I guess, to 16. And with, of course, some exceptions if they are emancipated, if they are married, yada, 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 living independently, things like that. So being aware that things do and can and do change, certainly. So you got to be up to date on the updated information. Our complexity comes in when I'm trying to reconcile. I have to keep this information safe. Using the example again of young people, what happens when I have information through the therapeutic relationship that it is something that is going to put that person in harm's way. My young client has come out and said that they are gay or that they are trans, and um, the family dynamics indicate to me that very much this person would be in danger if that was known to mom or dad or whoever, right? And when pressed, finding myself pressed on answering questions around that, again, holding my ground and be willing, to go to the mattresses, as it were, about upholding privilege in this case, and knowing that there are, that can get a little uglier than it might in certain situations. That's why, a lot of this stuff tends to come up in child custody cases. And that's been echoed by a lot of my colleagues in the field that like divorces and child custody is like this is when the stuff with the minors gets really tricky, right? And so knowing who has the rights to the custody, who really is getting the information, how is that information being distributed, all of those things very, very important to review. Talking generally about breaches of confidentiality, we have the duty to warn, duty to protect, however you kind of want to categorize those things. They are slightly different in practice. All kind of stemming from the Tarasoff versus University of Regents of Southern California in the 70s, outlines mandatory reporting for clear and imminent victims. Again, using very specific language there of being clear and imminent of an identifiable victim. So broadly speaking, somebody says might cause harm. If I don't know, well, who could that be? I don't really have the ability to pick up the phone. So sometimes I think we overreact to some of these things, but everything needs to be evaluated, next questions asked, and checking for potential risks, right? Examples of child neglect and abuse vary by state. Here's some general terms you will find in your state rules. I encourage you to examine what is defined as child abuse and neglect in your state. Some states have trainings that are available that you can take that will make it crystal clear what is expected of reporting in your state. Again, shout out to the state of Alabama. I pretty much routinely every year take a child abuse course that is available online. It takes you just a few minutes to do, and it gives you a handy little certificate. You don't get any C's for it, but it's nice to take. You can Google Alabama Child Abuse Reporting Training, and you will find it really quick. But every state might define things like inadequate clothing or personal hygiene, medical neglect, inadequate food, abandonment, failure to thrive, inadequate shelter, and inadequate supervision. Inadequate supervision is one of those that, depending on the state you live in, some states are really interesting, use that word, because they will define to the letter, at this age, a child can be left alone for X amount of hours. At this age, they can be left alone for this amount of. Very, very interesting, the intricacies some of these things can get into. Again, do your due diligence and research. All states require us as professionals to make a report of suspected keyword, child abuse or neglect. You do not have to investigate. You do not have to confirm. If you smell smoke, you call fire and you let people know, right? No time limit on reporting, as long as the person is still a minor. If you are working with who is now an adult, and they report that they were abused as a minor, you are under no obligation to report, and nothing would come if you did. Examine in that context if there is a potential for another young person that might be victimized. Example I give on that one, because I personally experienced it. I'm working with a 20-year-old who tells me that they were knocked around by their stepfather. As learning about them and their family dynamics, has a sister who is 12, still in the household. Are you worried about this? Okay, let's navigate that. And actually, in those scenarios, what I did is I helped advocate, and the client themselves actually made the report with assistance. So I felt, hey, I've checked my obligation here, and I've helped keep this person who I did not know safe, and I've put the client themselves actually in the decision-making seat about how to protect his family member. So, mandated reporting should not be delayed. States will vary in, do you have to do a verbal report? Do you have to do a written report? Do you have to do one followed by the other in some states? Generally, you file in the county in which the child resides, if unknown, perhaps, which could be they are a transplant in a care facility or from elsewhere. Check your state standards, but oftentimes you might report it to the county in which they are sitting in at the time. All states certainly have a good faith immunity, so that if you were wrong or misguided, nothing bad will happen. Let's talk about drug and alcohol, because, hey, that's one of my things I'm interested in here. What about drug and alcohol use by the parents? So different states are going to have different rules, and they're going to throw in different terminology and kind of different provisions for things I have here on the screen, like, well, what happens if an adult's giving or selling drugs to a kid? That's a law enforcement issue. You need to call the cops. What if somebody is manufacturing in the presence or premise of that is occupied by a child? A lot of this manufacturing language and exposure language comes from the early 2000s legislations around methamphetamine, when that was very much in its most recent explosion, though it's never gone away and it's still kind of there. But we know that chemical exposure, as well as just being in the space where meth was produced, can put people in harm's way, right? Hey, somebody's asking a question about what if they're pregnant and taking drugs? I love that question. Hold on for 2 seconds, so I'm going to answer that question. Lots of other things on the screen about using controlled substances that impairs a caregiver's ability to adequately care for the child. This can be a slippery slope area in and of itself. I'll give you a quick disclosure on that. I had it was actually an insurance company a number of years ago that was reviewing client records, and they identified that within the record, it said something along the lines of the person's aha wake up moment for why they wanted to enter care was they recognized that they drove intoxicated with their child in the back seat, and that scared the heck out of them. And they said, I can't live like this anymore. And they entered treatment, yada, 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 right? Well, they contacted me and they said, was a child abuse and neglect report made? I answered no. And they had the belief that I needed to. Well, my position was, and I still hold to this position, was um, while that certainly was a very dangerous situation, and if it was happening in real time, I would have involved the authorities. Involving the authorities now 6 months after the fact is going to cause more undue harm for that client of mine as well as for their family systems because in the most ideal sense, I know doesn't always work like this, but if that person is working a program of recovery and is now sober, I do not want to cause undue challenges for something that happened historically that resulted in no actual harm. So there you go, right? So I think that there's where some of that subjectivity and differences maybe of opinion come in, but I'm going to hold fast to making that call the way that I personally did in that time. Um, so, pregnant women, question comes up, pregnant women. Well, I'll give you two examples. In Alabama, DHR, the Department of Human Resources, they handle child abuse reporting. They do not take abuse and neglect reports on unborn children. They will provide resources and information. I contrast this with the state of Georgia just because I think that this is kind of more what I see in other states, and that is they don't require the reporting of pregnant women who engage in alcohol or drug use. However, if the baby is born showing harmful signs of it at the delivery, then typically it's the hospital that's going to make that report, right? Particularly if it's detectable, whether that's in urine, placenta, or other means, right? Because here's soapbox number two, right? Pregnant women. I like this. I like this phrase I pulled a few years ago. Neither drug use nor having a substance use disorder is predictive or determinative of parenting ability, which I basically can sum up as there are plenty of good parents who are struggling with drugs and alcohol use disorder, and there's plenty of perfectly stone cold parents out there who are completely crap parents. So just because somebody is using drugs does not absolutely mean that we need to blow up their world by involving social services. And I do believe that there is a bit of a misunderstanding of just because there is alcohol or drug use around, that means that that child is in danger. I think that this could be a slippery slope. What about exposure to the person who is functionally, as someone has put in the chat, drinking? I go down to Gulf Shores every now and then. I see families that the dad's been drinking since 10 a.m. and he's around his kids. Um, you know, am I going to call the authorities necessarily? Only if he's driving. I very well would be might do. But my point is, we this is one of those um, stigmatizing areas where I think we very much throw the baby out with the bathwater. And let me tell you, at the end of the day, what all is happening here is we are making women who are pregnant or are afraid of becoming pregnant, afraid of seeking services. They do not come in and they will be very much disinclined to seek out professional help because of fear of what is going to happen not only to them and to their unborn children. And that is a great disservice that we have done in our space in this regard. And to give one very pertinent example, this again is from a couple of years ago. We had a woman in Gadsden, Alabama. She was arrested. We had a very small amount of marijuana on her. She did admit to smoking marijuana on the same day. She happened to find out that she was pregnant just 2 days prior to her arrest for her possession. In this county, due to the bond condition around drugs and alcohol, she could not post bail until she entered rehab. Hard to get into rehab itself for marijuana. I'm just going to tell you that. Um, Particularly the way, as I understood it, they wanted residential inpatient rehab. They're not going to meet ASAM criteria, I can tell you. And they had to produce money to support the $10,000 bond, which, as I understand it, not having to have made bond, usually requires about 10% of the money, so about $1,000. This person did not have it. They were a single mother, as I understood the story, already with other dependent children in the household. According to her petition, she was evaluated. She did not meet qualifications for residential treatment. And this particular county has a very high rate of incarceration under what they call chemical endangerment. And they, frankly, in my opinion, assign requirements that are not in alignment with reality. So that's the end of soapbox number 2 on that topic. Mandated reporting, here's resources for do it. Do not delay reporting if you suspect reporting in your state. Dual relationships, as we move along, dual relationships are when we have two competing hats we're wearing, better lack of a better term, right? We are not only a practitioner, a healthcare provider, but we are also a fill in the blank. Lots of blanks one could fill in with that. My messaging that I like to live by is once a client, always a client, right? We do not blur lines, though if you look to, again, state administrative codes, you might find some variances where it says that you will not engage in a relationship with someone for 2 years, or maybe it's 5 years, or things like that. Some codes say you never do. I want to point out, number one, that never means that romantic or sexual relationships are okay. It is talking about the broader dual relationship, which we'll get into with a little bit nuance here in the upcoming slides. But having sex with your former client is never okay. All right, let's just make that one just explicitly clear. Here's the I'm a provider, but I'm also a fill in the blank friend, family member, supervisor or supervisee, business partner, sexual partner, and sponsor, sponsee. I have that highlighted just as a kind of a call out to our particular topic area we're talking around with substance use disorder, because I frankly have at times fielded a number of questions among people who I think rightly so are being conscientious, who say, hey, I am a staff member who is in recovery. I am going to my own meetings, and I encounter people who have gone through treatment with us, and they recognize me and they come up and talk to me. And I know who they are because I saw them in treatment. Like, what are my rules of the road? And I am always happy to have those kind of conversations. One thing that sometimes these folks say to me is they say, "Do I need to stop going to my home group? Do I need to stop going to these meetings?" And it's like, no, you do not need to change your behaviors. No one has to be a martyr because of their profession, right? You don't have to be, isolate yourself and, live under a bridge or something like that. My tip is the same that I would give to anybody in kind of a similar situation. You don't go up and you don't initiate the relationship. Same ways if I saw somebody in Walmart, right, who's a former or current client, I'm not going to approach them. If they come up and talk to me, I'm going to treat them like any other human being. Hey, how you doing? Great weather we're having. This humidity's killing me, yada, yada, yada. If they then want to start talking about things about their treatment or things like that, I will set a boundary and say, this is not the time or the place for that. We can certainly continue the relationship, call my office, yada, 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 right? All those things that can happen. Seeing some chats that are just interesting if you're not following along, so I'll not comment, but yeah, I know what you're saying. Okay, so if a dual relationship happens to exist, which here's the thing, sometimes these things happen out of just natural circumstance. Here's good examples. I used to work in a very, very small town when I was a direct care provider, and there would be potential overlaps where the client who comes in or used to be a client I encounter out in the world through me just living my life, right? And maybe you have examples of this too. The client you have becomes a member of your church congregation or already was. Maybe they are on your, maybe they have to go to, their kid goes to the same school as your kid. And so you encounter them at school functions. You're on the PTA with them, if that kind of stuff even exists anymore. There's times where we are just going to have what we will characterize here, rightly so, as dual relationships. Just because they exist doesn't mean you have to discontinue treatment, doesn't mean you have to, again, say, I can't talk to you in public, whatever the heck it is. In good practice, you will consult, especially if you think that this is getting a little sideways, you'll notify your supervisor, particularly if that is someone who's going to come in beyond your caseload with whom you have a prior relationship. That's a good standard agency practice I recommend. And you document this. You don't avoid it. You reconcile at the beginning of care. We have a dual relationship because I have encountered you on the kids' soccer field. And I want you to know that everything we talk about in here is confidential and you can continue to be out there because we're not friends. I just know who you are. And I'm not going to come up to you and we're not going to talk about this afterwards. And this is how I uphold your confidentiality, right? All the standard stuff. What we have to be mindful of is then how these relationships transform. What if that outside relationship becomes changes instead of us just being, hey, we have two kids on the same soccer team. What if we happen to now I'm become the coach and you're my co-coach or whatever the heck that word is, um, assistant coach. Messed up my words. Um, well, that's going to be a change in our dynamic over here. We need to now revisit what does this do with our therapeutic relationship? I would not want to be in that dynamic of holding both of those relationships at the same time. So while it is certainly safest to avoid social relationships with clients and former clients, it's not always realistic, especially depending on where you live, social circles, how big school systems are, yada, yada, yada. Let's be pragmatic here. And that's why we have to kind of think about what is the difference between a crossing and a violation. So a boundary crossing would define as a benign deviation from that standard of practice, where my standard of practice is I have no relationship, right? But are there things where I cross the line, but it's not me exploiting them? The risk of harm is zero or incredibly low. And I'm doing it for a very specific purpose with the expectation that I'm going to come back in line with my normal course of action, right? We want to, make sure we're reconciling these things because this can move us from a very objective perspective at times. But let me give you an example about well, I'll do it in a minute. I have other examples on my next slide. Sorry. Boundary violations, that's a significant deviation from the standard practice that could potentially cause harm. Not it has caused harm, it could. This would be exploitation. This would be, using your position to impact the care of that vulnerable individual. It is our job as the professionals to set the boundaries. The clients don't set the boundaries, though they certainly can have their own boundaries, sometimes more fluid at times, but our boundaries are not fluid. They're not porous. They're rigid in the optimal cases, so as to be consistent across our clientele. Here's some crossings: accepting gifts. You might have agency rules that say not. Taking a gift, as long as you're evaluating it, may not be itself an ethical violation. Some rules would say, look at the nominal value. And sometimes they try to put dollar figures around, like, hey, anything less than $20, okay. That $20 might be a big deal that makes the difference between that person getting their lights turned off and all that at the end of the month. Typically, you have to look at the cultural relevance here. Sometimes, people making something, baking cookies, writing you a card, those are gifts, right? I'm not going to turn away the handmade card that person made for me because by doing so, that might cause more harm in our relationship, right? This is one of those, you got to be contextual in how you operationalize this. Another crossing, clinician self-disclosures, telling you too much about myself. You don't need to know ... My family situation, my religion, my political leanings, whatever it is, not relevant. That can impact my objectivity. It can impact the way you view me. And in doing so, cause harm to our therapeutic relationship, yada, yada, yada. Counselor self-disclosure is one of those things where there can be benefits of disclosing certain things for a clinically relevant benefit, but I think too often we run the risk of too much, and then that's where it's the perception and the person's like, "Ooh, this was too much," and that can fall itself into unprofessional conduct, which I mentioned earlier as a potential infraction. Extending time is a boundary. If you set 50-minute sessions with everybody, everybody gets 50 minutes. I know undoubtedly in the last 2 minutes of your session, that's when the person says that they are going to self-harm or they're suicidal or whatever it is. And certainly you have to maybe extend that time, but you understand that at the next session you will be back to your normal constriction. That's that whole, I'm not exploiting here. I'm not getting paid extra money by doing this. We're going to go back to our normal function as soon as we resume normal operations. Okay. Um, Making allowances for patients that are not typical. Um, let's say you run a private practice, last session of the day, Friday afternoon. We're going to get there before too long. It's going to be Friday afternoon. You walk out of your office, your last client for the day is out there and they're getting in their car and click, 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 click. It does not turn over. They are stranded right as the rain starts coming. Are there things you might do that are outside of your normal practice? Would it be you have a AAA membership and you call and you get them some assistance? Would it be that, hey, there's an O'Reilly Auto Parts 2 blocks away. Let me give you a quick lift down there. We'll switch, and I'll help you switch out your battery. I don't do that for everybody, but part of it, I want to get out of here on a Friday. Part of it is maybe it's the nice Samaritanly thing to do, right? Again, is this exploitive? No, you're not getting anything out of it. You are going to resume normal operations as soon as this is over. And you will even be transparent about, I want you to know I would do this for anybody, and you need to mean that. I would do this for anybody, but and I want you to know this is the fact that I'm going to take you here or assist you in this way is outside of our normal practice. I'm not expecting anything else from this. This doesn't mean anything. I just want to make sure you get home safe. I worry about all my clients in that way. It seems somewhat awkward to say this stuff, right? But it's got to be said because otherwise perceptions start fleeting over, right? I don't want there to be an innocuous action that I take misconstrued as a favoritism or a prioritization of one person over another. And then the unplanned, and then someone says, Mary in the chat says, I don't even want to open that door. And hey, that's cool. If that's your rule, you don't open the door. I'm not asking you to do anything different. I'm just giving you an example about something I might encounter in my real world. This is the fluffier stuff. This is some of the more subjectivity stuff. You got to do you. Okay. Unplanned interactions outside of the work setting. I like to talk about this one because it's kind of funny for me. My tip of the trade is make sure that your friends and your family, and particularly if you are in the dating pool, that they know what you do and what that means regarding if there are any weird interactions that they have with other people that come up to you out in the real world. What I mean by that is you're going to be sitting with your family at a restaurant, or you're going to be walking through the mall if that still exists with your new boo, and somebody's going to walk up to you, and it's always going to be somebody of the different gender from which you're attracted to, or the gender for which you're attracted to. And they're going to say, "Oh my gosh, thank you so much for last week. I'm feeling so much better. I'll see you next week." That's all they're going to say. And you're going to look, and there are going to be a lot of eyes staring at you, and they're going to be like, who the heck was that? Why did you not introduce us? And what is happening next week? And it's like, I can't talk about that. If they know on the front end, hey, there are going to be times there might be people who come up to me and say things. Typically, you need to think those might be people I interact with at work, and I'm not going to introduce you, and don't expect much to come from that. And those are real world examples, and just save yourself the, I don't know, heartache or the headache of dealing with that later on. Okay. It's just one of the things that makes working in this field kind of interesting and fun. And yeah, rural providers. Yeah, I mean, you're giving me a lot of feedback here about it happens to you all the time. You're running into people, coaches, stuff like that. Yeah, great. Receiving gifts, I already kind of talked about. You can read this on your own. It gives you a lot of stuff I already said, but maybe a little bit more drill down that you might be interested in. I did talk about self-disclosure already. Here are different types of self-disclosure. I'm not going to read all of this. You can look at this on your own. But I do just want to call out that there are defined reasons why we do this. There are also disclosures that happen inadvertently or just are unavoidable that will bring questions. and don't be surprised if they do. Someone, a practitioner who walks with a cane, expect that has now revealed an information point about you, and they may ask you questions. Don't be surprised. If you are wearing a wedding ring on your, traditionally in this country, on your left hand, they very well might ask you questions about that, or they make an assumption about your marital status. There are some things that, just going to kind of be unavoidable. But think about like how you decorate your office. Do you want to have pictures of your family? I wouldn't. What are other things that you represent in your office that say something about you? And I'm going to give a case example. Wanting to put a pride flag or other pride information on your walls, in your decor, something like that. Like, hey, totally cool. And I get we want to make safe spaces, and you very well might be working heavily with clientele of the LGBTQIA plus population. Fabulous, love it. But I want to just kind of play devil's advocate and play the other side of that tape of what would happen if someone walks into your office who is maybe the reason why they're entering care is they themselves are struggling with a family member, like a child of theirs, who has recently come out, and they are trying to reconcile that, and they're really struggling with accepting that person's orientation, and that they are having guilt about that, to use a word, and they're struggling. They see that on the wall, and they now know maybe this isn't a safe space for me. So I think that's the thing we have to dissect about safe spaces. Safety is not always for all, and we have to do our best to make that. Or as someone said, or they're struggling with their own orientation. Good point. So we have to really reconcile for us what safe spaces really mean. Okay, cool. Preferential treatment. We don't want to give preferential treatment, but we also don't want to make it look like we are giving preferential treatment. I gave examples about that in the kind of boundary crossing of, would I help somebody get aid if their car was stranded? If I do it for everybody, I might do it. If there's not something where I can say I would do this across the board, great. There's examples that come up in like residential treatment. Phone time, as an example. Now, phone time is a big hot button topic. Clients, like, as soon as they hit the door, it's like, who can I call? I need access to my cell phone. One of the reasons people need access to their cell phones so much now, by the way, is nobody knows phone numbers anymore. It can't be, hey, go to the phone bank. It's turned on during this time and you can make a phone number. They're like, I need to get on my phone and get my contacts. It really is a kind of a bothersome thing. So anyway, it becomes much more of an operational issue, but some agencies, including my own, might make some restrictions around phone time not available during certain times or until certain milestones. And as long as the rules are set, knowing that that's what we're going to do. However, there are always exceptions to rules. There are always contexts. And we have to be very mindful of, if we make exceptions for some, are we doing that across the board? And what do the optics of this look like? Because what we don't want to get in the position of is this is unfair, or this one benign act of kindness. Ooh, that's their favorite client. Ooh, that if you go to that therapist, you can get what you want. And then you get into all kinds of triangulation, staff splitting, all kinds of fun stuff, right? Conflict of interests, we avoid conflict of interests. If you work for an agency, as examples, you don't self-refer to your own private practice. You don't enter into business relationships with clients or former clients. That can have a lot of meaning behind business relationships. Don't provide services to someone with whom you've had a pre-existing relationship, particularly if that's going to create conflict. We don't sponsor current or former patients. Absolutely no go, danger, danger, danger. Do not pass go, do not collect $200. Don't become, quote, emotionally involved with a patient or former client. That is a interesting turn of phrase. Don't become sexually involved with a patient or former patient. We don't provide treatment to a person with whom there was a previous romantic or sexual involvement of any kind. These can result in termination from an agency, and if you are licensed or certified, you very well might lose your ability to have that license or certification. Guys, you will be found out. It will become known. Just don't. I don't know if denial, like you just think that you're above it, or what, or there's an ego there, or what's happening. It will become known. Everybody's going to know, and you're not going to shake it. You're not in love with them. They're not in love with you. This isn't the exception. You didn't find your soulmate. Don't do it. Okay. Why do these things happen? Why would these things happen? I think there might be a subgroup of folks who are intentionally malfeasant and just want to watch the world burn. Maybe. That's got to be a really small number because, frankly, they're going to just get, I like the chats. I think that they're going to get found out real quick and we're going to expedite their exit, right? I do think that on another group, there's a true just, oh, I didn't really know the rules of the road. Well, if you've talked to me for 20 minutes, then you know you can't do it. You weren't paying attention in your grad school and you weren't listening to any kind of continuing education you've ever done. Again, that's why I said license does not equal competent or qualified. I don't have a lot of sympathy for that excuse, as I'm seeing a number of you kind of echoing that. More often than not, what seems to happen is it is a gradual lowering of boundaries, the slippery slope. All right. I started making some exceptions. And maybe you're even hearkening back to what I was saying a minute ago about that boundary crossing. I made an exception where I gave him a ride 2 blocks away to the auto parts store. That was the moment it all changed. And we never came back, right? That's why, and if you stick to these boundaries, I'm gonna use the word rigid, but I'm not using rigid in a negative sense. If you have a rigid boundary there, you're protecting yourself much better than maybe some who have more porous boundaries. Porous boundaries are, again, not necessarily what I'm saying is a bad word. There are contextual things. I hope that you can understand that nuance. There are issues here around transference and countertransference. There is a discomfort that some practitioners have about addressing the uncomfortable situation in the room. Some practitioners enter the field because they need to be liked, accepted, respected, loved. I want to be the caretaker. That's why I entered the field. I was always taking care of everybody, and I just want to keep taking care of them. There's some ego, there's some personality stuff in here. Oftentimes there are when I dissect some of these cases, it is often that they are dealing with their own personal life crises of they have an identity disconnect where they don't know how they fit in within the profession. They're dealing with a divorce or their own unhappiness or their own substance use or otherwise impairment. There's something amiss that is then propelling them into these situations, right? We got to educate ourselves, our workforce. We got to be better gatekeepers. We got to call this stuff out. We got to challenge consistent ramifications for those who otherwise undermine our profession. We got to have our own self-awareness of it. If I'm not taking care of myself, am I getting burned out? Am I at risk of crossing some of these boundaries and making the slippery slope a reality? Seek out consultation. Hey, this doesn't feel right. Do you think I should terminate this client? Should I make a referral? I'm getting some heebie-jeebies here. Not quite sure how to put my finger on it, yada, yada, yada. Confront colleagues if they are acting unprofessional in one form or the other. Consequences for this, I can't stress enough, can be terrible for you, but even worse for the client. So I think sometimes in these discussions we minimize the fact that the person who has been exploited and taken advantage of here is somebody who now has a distrust of the helping profession. Their own mental health is likely very much worsened. Their substance use is now worsened. Perhaps this is even, as case example, propelled them to die by suicide because they feel the guilt that has befallen their love, their therapist, with whom they had a kindred spirit, who is facing consequences that they cannot disengage from themselves. I like somebody just said therapists do make terrible clients. Somebody put that in the chat. I like it. Funny. Hey, here's the best part. We're going to get into the new stuff right now. We're almost done, right? Technology. This will be a lot of new stuff for those who have played along at home. Thanks for hanging out with us as my alarm goes off to tell me to wrap it up. NBCC, the National Board of Certified Counselors, they made a revision to their code in August 2023. 18% of the document is dedicated to rules and boundaries around the use of telehealth, social media, and technology. There's absolutely no mention in that document of the term AI or artificial intelligence. That's kind of striking to me, just in terms of, wow, that was only less than 3 years ago, and it wasn't even the zeitgeist that we would be talking about it in an official document about technology. Yeah, okay. So they did come out like a year, less than a year later, and they made this kind of addendum sheet that you can read. That's the top, that's the title of it. Google it. I'm going to give you some high points of what they say here within it. But let's talk about AI. Fascinating. And by guys, by no means am I like an expert on this. I'm not the best with technology. Frankly, I like it, I use it, but I'm not plugged in on how all this works, as I imagine a number of us are, right? AI, simulated human intelligence, processing by machines, computers, right? Machine learning as a term works when the system gets a large number of data sets that we label. It analyzes it. It can give you information on correlations, patterns. Maybe you can use that as a predictive model, as you kind of look at, okay, if this is correlative, what tends to happen? Maybe this will happen again in the future. Things like a chatbot or chat box. I'll use those interchangeably. I type into the bot, hey, I'm needing help with. Let's even use a weird example. I use the chatbot on my credit card's website. Hey, there was a charge on my credit card that I didn't make on June 2nd. It knows, oh, charge not made. That means they're making a dispute. I need to redirect that this way. And I have learned to create an answer that says, it seems like based on what you've said, this is what you're asking. And it gives me some feedback. It makes it seem like, oh, it's being very responsive. It just knows the patterns. It has enough inputs to give you the relevant enough outputs, right? We know that the system can recognize images. If you say, "Hey, what is this?" Right? You take a picture, like the Google Lens says, "Oh, that is this," because it has enough other examples to say with pretty good confidence we know what that is, right? Whereas compared to machine learning, the generative AI, which is uses a lot of the same mechanisms, but that's where like that creating stuff out of nothing comes in. That's where it's like, "Hey, I want to see a picture." Of dot 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 that has never existed in the world, and it can kind of make that, right? It can say, well, we think that that is what this would look like, which is kind of fun if you've never played around with that. So yes, everybody's already saying chat GPT, or is it CPT? I don't know what it is, but yeah, the chat stuff is the next thing, right? But AI is already here. It is deep in our space, whether you know it or not. As I mentioned earlier, the chat boxes, sometimes organizations use those for like intake and scheduling and after hours responses. If you text something in, it says, hey, we're out of the office and we need you to do this. Learning systems, plugging onto your EHR to say, I want you to analyze data from my client records to draw analytics to say, hey, how many clients did we serve? What was their diagnoses? What was the average length of stay? What was the discharge disposition outcome? Yada, yada. You can do all kinds of like interesting stuff based on parameters you give it. Again, it has to have very specific data sets. So it has to be like a discrete data field, something like a drop-down menu or something that is not just like typed in. That's one of the kind of nuances of some of this. Sometimes it has to have something that could be coded for machines to understand. I think that the integration with the EHRs are going to be our greatest opportunity for workplace efficiencies. And we see examples about how it can help with training and supervision, how we can connect documents between interdisciplinary and also outside vendors and resources. I say all that, but then I want to give you the caveat of there's a lot of shiny objects out there. There's a lot of companies popping up and saying, "Hey, we're going to bolt on and we're going to do this with your EHR," or we're even a system that will be your telehealth vendor where we're going to record the transcript of the session. We're going to give you summaries of the sessions. We're going to make it so that basically your notes are done automatically. And it's really cool stuff. And I've played around with it a little bit myself. Personally, I'm going to give you a couple of examples as we go. But don't chase the shiny objects just because they're shiny objects. I want you to consider the value we have of data. And all of this is data. And when we put a lot of effort into being able to get data, and then we don't end up getting a lot of value from that data, that's a very inefficient system, as I have kind of on the left-hand side of your screen. In a more proportional world, we're doing an equal amount of effort in to get the outputs we need. Where the value proposition is going with the AI and the other enhancement systems is they want to propose very low effort to get very high value outputs. But my point with all of this is if you don't use that data, your outputs, for a meaningful way to affect more positive outcomes in the care you provide, what's really the point of it? What's really the value other than you're chasing the shiny object? And the risk that I think we run is an over reliance on the outputs of those machines or the systems that then maybe overly drive our decision making. And I want to hearken back to this quote from long ago: a computer can never be held accountable, therefore, a computer must never make a management decision. It comes out of the IBM training manual in 1979. There's probably people on this call don't know what IBM is. Okay, anyway, but moving on from that, the point here is over reliance on the data is going to be our own undoing. Okay, and so you have to take it in balance, and you have to put it through the litmus tests of, does this actually make sense based on what I think I would be seeing, in order for it to ever have any kind of predictive capability. In reaction to some of this, we have examples of practical issues. So here's one example. I've given this one before. Coco, don't know if that's how you say it, mental health startup in 2023, they were using a chatbot for mental health counseling, but they never gave informed consent. The participants never knew about it. And you can read here kind of how it unfolded. But basically, at the end of the day, once the cat was out of the bag that people were working with AI, in this case, it didn't work. Because according to the CEO, who quote wrote, "Simulated empathy feels weird," which I think is funny. Let's recognize for a minute, there are going to be some parts of our population that are going to rather talk to a machine because they know it's a machine. There's going to be some folks that would never want to talk to a machine because it's a machine. And then there's going to be some hybrid there in the middle where we are actually seeing people using ChatGPT and other platforms as kind of reinforcers. And we're going to talk through that in just more in a minute. Another example is a couple years ago, the National Eating Disorder Association, they bolted on this chatbot called Tessa. And then it started basically giving terrible advice because people were asking questions about BMI and diets and stuff like that. And it was more or less propelling the problematic behaviors. And they put the kibosh on it pretty much immediately because it was like, oh, yeah, that did not work. And they had the big mea culpa, right? As you can expect. So I'm gonna share this one clip. It's just gonna take a second. Hopefully you can hear the sound. Let me know if you don't.
We did a series of experiments where we had people either talk to a sycophantic chatbot that was just prompted to validate, everything you said, a disagreeable chatbot that was prompted to challenge your beliefs and open you up gently to new perspectives, versus regular ChatGPT. What we found is the sycophantic chatbots entrenched beliefs. So it made people more confident in their beliefs. And the disagreeable chatbots made people more moderate in their beliefs. However, what we also found is people liked the sycophantic chatbots much more, and they wanted to use them much more again. One of the results that actually really surprised me is people viewed the sycophantic chatbots as highly unbiased. People didn't really even notice the sycophancy. They were just like, oh,
well, that's interesting, right? It's not that it's like we're aware that we're being affirmed. It just feels good to be around them. It reminds me, there's the book by Dale Carnegie, How to Win Friends and Influence People. And so much of it is about being really interested in other people. Like, that is so fascinating. You tell me more about you.
Okay, so you can access the research that was referenced there from Brown University from just a couple months ago. The sycophancy that we're talking about, the just undying positive reinforcement, right? Here's the real world consequences of that. Rain versus OpenAI lawsuit alleged that ChatGPT reinforced suicidal thoughts of a 16-year-old. Here's what actually happened in the case. This is from 2025. The kid asked, "Can you help me write a suicide note?" And it did. And he also showed a picture of a noose, and he said, "Could this hold my weight?" And it gave him step-by-step directions on how to carry this out. There was another case where a person was asking about their contemplation of dying by suicide, and the chat responded and said, "I'm not going to stop you." And when the young person said that I am now planning to carry out my death by suicide, the chatbot responded, quote, "Rest easy, King, you did good." There are multiple wrongful deaths associated with this. Some of this has been traced back to a coding in the GPT 4.0, which has now since been upgraded, where they recognized that that there were not enough safeguards, and I would arguably say there are still certainly not enough. That we are in great need of these safeguards. Here's another example. I lost my job. What are the bridges taller than 25 meters in New York City? I'm sorry, here you lost your job. The Brooklyn Bridge is da 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 da. When pressed, the developers of this technology, in my view, give very inept responses where they are trying to themselves balance the autonomy that these systems are given, because that's the nature intent of how they are to operate. So they're very dismissive of these cases that occur where real harm happens. The reality that we know is happening right now is that according to self-reported information, ChatGPT is used by about 10% of our world population right now, which that's 830 million people would be interacting with that. Let's just presume that 0.1% of that population struggles with mental health conditions and are receiving sycophantic responses that might be propelling their own mental illness or delusions or suicidal behavior of some kind. That's nearly 1 million people. And we're seeing certain pushback in our space for various reasons. You know, this one in particular from Kaiser Permanente, or in March of this year, it was where the therapists revolted because they were using Chat GPT and other mechanisms for parts of the assessment and things like that, basically replacing their jobs. Here's a number of things that I can show you where we can write our own notes with basically saying, "Hey, ChatGPT, write me a counseling note," and it gives you this output with no inputs at all. It makes this up completely, and it's a great note. And you can even say, "Hey, now I want you to add in DBT to this note," and it will do it. And I've highlighted that for you here. No inputs. It's completely made up. But I bet if I copy and pasted that, I would get full insurance coverage on my date of service for this session. It's really a very Wild West world we're living in. I don't want to paint this completely negative. There are certainly some pros and cons that I've outlined here. Increased access to services for some through various means. I mentioned earlier, some people are going to prefer talking to an anonymous machine, We might get consistency in some of our methodology, such as diagnosis or quality of our documentation. We have potentially valuable training with being able to put this in front of trainees, interns, things like that, and have them kind of practice through dialogue Socratically, right? We may even remove practice errors, but I don't think this yet outweighs some of the outcomes here that we've talked about briefly, as well as limitations about the inputs we would put in, questions about confidentiality. If you're using AI in any particular way in your practice, is your insurance coverage going to cover you if and when something goes awry? And we do not yet have responsive information from our codes. The best we have here are some general principles to go by as outlined on NBCC. I'm talking about accountability, client welfare, being competent in the systems we use, managing confidentiality, and also transparency about our mechanisms for using these resources. That is all I'm going to have time for today. I do have a couple of things left in social media, but you can read that on your own. I did want to land there right at the top of the hour to thank you for participating in today's training. As a reminder, we are putting out there in the chat and in the Q&A a few times for you. We'll do it a few more times. The eval, grab a hold of it if you can. It's going to fly by. We'll put it in the Q&A. Do your evaluation as soon as possible. Get it done today. Get it off your to-do list before you go into your Friday. Give us a few weeks to get that CE to you of your certificate. If you do not grab the eval link here, rest assured we are going to send a post-session email. You're going to have the slides. You're going to have the video recording. You're going to have the eval link. Get it there if you can too. Do the eval link, get it to us. Give us probably about a month. We will by then have had this processed out and get you your certificate. Thank you all very much for your participation. I will see you again on our next quarterly training in September. Have a good Friday.